wonder there is absolute peace in the region. Most importantly, the traditional leaders saw need to make him the president of the National House of Chiefs, so they elected him. Ladies and gentlemen, I'm proud to introduce our chairperson for today's function, Ojia Hopo Yao JB. Please, let's give him a round of applause. Nana, before you come, I don't know if Spendilove Opoku is here. Spendilove was supposed to pamper you with some traditional, but if Spendilove is not here, then we'll accept it. Okay. Spendilove Akitinebre, Aduano Fabeji Nana, so that is tradition, Nana, so now you're welcome. Nana can come in. This is tradition at its best. For those who have joined us, in Africa, we revere our leaders so much. Nana is garnished by other prominent traditional leaders. Ojia Hopo Yao Your Excellency, the First Lady, Rebecca Akufo-Addo, Dr. Mrs. Wiafe, President, Breast Cancer International, the Honorable Minister of Health, members of the Diplomatic Corps, members of the clergy, eminent oncology professionals here in house, and the very many others online. Other participants and our online participants and audience, Mananom, distinguished ladies and gentlemen, I am extremely delighted and grateful for the opportunity to be part of this conference. A conference with an array of eminent oncologists and other health professionals from around the globe to share expertise and knowledge on no mean subjects than oncology. Cancer is one of the leading causes of morbidity and mortality worldwide. Globally, nearly 1 in 6 deaths is due to cancer and complications of cancer. I have learned that the Lancet Oncology series include papers that take an in-depth look at a topic of special interest to explore new thinking that look at a topic of special interest to explore new thinking, that take advances oncology and healthcare policy. I am therefore expecting that this conference will provide the knowledge and skills that will improve policy making in Africa and effectiveness and timeliness of cancer screening, diagnosis, treatment, and outcomes to provide more equitable cancer prevention and care in Africa. I am also hopeful that the new knowledge and skills in cancer prevention and care will be shared to elevate the practice of oncology in Africa and contribute more significantly to the development of the continent. I am indeed grateful for the opportunity, and with the assurance of your support, I humbly accept to to chair this function. God bless you all. You are welcome.
The traditional leaders, a bigger round of applause. Thank you. So Nana Chairman has accepted to chair the function for us today. And when you have the traditional leaders at your program, it only tells you the land has accepted the program. Ladies and gentlemen, we may now carry on. At this moment, it's only kind for you to hear a bit of, so what is really happening when we mention the Lancet Oncology? What are we saying when we want to commission such papers? I'm sure there are several practitioners, health practitioners already who have a fair understanding. The press is also here in their numbers. Before I even go on, let me also salute the presence of one great woman of the land, Professor Nana Opoku Ajiman, former Vice Chancellor at the University of Cape Coast. Please, let's do her a big round of applause. Mommy, we all appreciate you. Thank you so much for being present here. At this moment, ladies and gentlemen, like I mentioned early on, you need to be given a welcome brief. And he's been putting all the papers together. He tells me, look, the job is still ongoing. The updates is still happening. For now, for those who would need it for research and the like, you just need to launch onto the portal and you would have every information that you desire. Ladies and gentlemen, not to take much of your time, help me welcome Professor David Carlin-Ridge. He is the Editor-in-Chief, the Lancet Oncology.
Good morning. Dear Excellencies, distinguished guests and colleagues, it's with great pleasure that I stand here today to welcome you to the launch of the Lancet Oncology's Commission on Cancer Control in Sub-Saharan Africa. Following many years of discussion in many academic fora, this project formally came into being in June 2019. And the project was formed as a holistic exercise to take a view of cancer challenge across the African continent as non-communicable diseases start to overwhelm healthcare systems. As you're all aware, in Sub-Saharan Africa, with 46 countries, a total population exceeding 1.1 billion people. This continent has long suffered high morbidity and mortality driven by infectious diseases, malnutrition, and poor maternal and child health. But it is now also being afflicted by the growing incidence of cancer, a disease that in high-income countries affects 1 in 2 people. This double burden of disease is a consequence of lifestyle and behavioural changes, a shift in population demographics to an ageing society, and etiologies caused by globalisation, genetics, infection, and environmental factors. The health of the people in this part of the world, where fragile health systems are under-financed, under-resourced and understaffed, needs urgent global attention. Cancer incidence in Sub-Saharan Africa is estimated to have doubled in the past 30 years. And without effective interventions, the number of cancer deaths in this part of the world is expected to exceed more than 1 million people per year by 2030. Today, the Lancet Oncology publishes a commission, 2 research papers from the WHO and a series of commentaries on cancer control in Sub-Saharan Africa. In this morning's symposium, you will hear from the lead commissioners who oversaw this project, which included 53 internationally renowned cancer experts, many of whom are from African nations. You will have an opportunity to question experts about the cancer epidemic we all face, and the solutions that have been proposed in their comprehensive report. You will hear a number of recommendations for actions that should be prioritised and implemented as a matter of urgency, including establishing and maintaining robust cancer registries, creating effective cancer control plans, incorporating cancer control into universal health care, early cancer screening and detection, incorporating palliative care into the cancer care pathway, building and training the oncology workforce, boosting cancer research, and increasing the use of telemedicine and other new technologies. Further, the report emphasises the need and the importance of implementation research to improve clinical care pathways and enhance service delivery. And finally, in terms of resourcing, the commissioners suggest that funding should initially be prioritised for the most cost-effective measures, such as prevention, vaccination, and more affordable treatments. They recommend that transparent and dedicated revenue streams should be established, with input from international collaborators as needed, to finance specific control measures. Now, although every nation will need to adapt these recommendations to best suit their own specific needs and situations, with political determination and coordinated approach across the region, improved cancer care is achievable. As the quote on the booklet that you will receive later says, "We have seen too many reports, too many words, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in collective action." So finally, I'd like to thank you again for attending today's launch and for the opportunity for us to be here in Accra on such an auspicious occasion. The time for action is now. Thank you.
Sorry. Thank you. Please, let's do more for him. Let's give him a bigger round of applause. Indeed, the time for action is now. Ladies and gentlemen, once again, those who are just joining us, let me welcome you. It is the Lancet Oncology Commission launch event, and this is being streamed live. It is being watched all over the world. Ghana, I must say, is very excited to be hosting this event on an international platform. At this moment, we would want to receive one fine artist in Ghana. She is ageless and she performs to the core. Ladies and gentlemen, I'd want to welcome at this moment our renowned musician and also a breast cancer ambassador. Let's welcome Akosua Ejapon.
Kevin,
All right, so let's give it up for Akosia Japan. Yeah. And she's committed. I mean, very talented. And like I mentioned to you, we watched her when we were young. So I keep wondering. Now when you put her by my side, it's like we're the same age. And yet on my father's black and white TV, I was watching this lady. Akosia, we're proud of you. And for you taking the initiative that, you know, you would carry on with breast cancer advocacy is a big thing that Ghana is proud of. We celebrate you. Please help me give her another round of applause. Ladies and gentlemen, the next area we'll be going to is very critical. But before then, I'll bring in another performer. Now that will allow me space to set up the place for the talks to begin. So kindly bear with me on that one, that I'm bringing the performances at this point, because then it gives me room for me to set up. But it is the reason why we provided stationery on your table, so that at this point you could collate and put together some information, because then we delve into the presentations itself. In a while I'll bring Prof. David again, but before I bring him in, let me, for those I didn't introduce with all the garnishing, let me bring in Osei Crunchy. Osei Crunchy is from the School of Performing Arts, the University of Ghana. He has assured me that Kweku, I'll clear all your backlogs for you, and those that you couldn't celebrate the way they wanted you to celebrate them, I would do so. Please, let's give him a big round of applause as he comes in with the traditional instruments to just give you a quick performance.
Thank you, Mr. MC. I'm going to present to you Seprewa, the traditional instrument of the Akan people of Ghana, the soul of Ghanaian high life music. Seprewa is made up of 3 Akan words. Se literally means speak, pre to touch, wa small, something small. So this small instrument speaks when it is touched. And was discovered around 16th, 17th centuries. 1961, my grandfather called up Pemini Kwabena Ejako, Western North, Seviamiaso, had a dream and rediscovered this instrument. He taught me how to play. The title of the piece is called Monia. Well done. And it's all about Lancet Oncology Commission. Congratulations. Traditionally, to mention a few names. Nana Oje Ahofo Kakujebi II, the President of National House of Chiefs, and a member of Council of State. Nana Mwakwa Bodu, the 8th, Central Regional House of Chiefs, Omahinov Bremai Esikuma. Nana Oparekwa Fabri Chidomhine. Nana Apiaje Dankawaso, President General West Africa Nobel Forum, Omahine Chiabe, Asantiabe, Anajwa, Joanna Eche. I'm doing that because the instrument started from Paris, was discovered by the Osetutu. So this instrument belongs to our traditional leaders. Akwaba. my friend, why are you in? I couldn't tell you why. Or maybe a year later, upon so. Oh, my God, so. Yamia any more, I'm a flower, dear. Mamma, swear, dear. Say, yes, so my young man, be an person bonity by Dr. Penny Pa. Ready, I would also. I just in a sense. I did. Sunday, I am a young found dear. Doctor, we are fair there. No penny for your money. Now, I know now. Ajuma could be a patria for so. Actually, woman, book and cassa. And then the family be a kind. And your son, we are here. Yeah, but I did. I'm a money to my pa. More money. Africa, Bedamos. You will be remembered. I'm feeling oh, money, yeah. More. I'm a money to my pa. More money, yeah. More money to my pa. More. It's my better myself when you are much richer, much wrong. Mamma, Adam was a mamma near to my pa. Yadia crown cray. Adia Marco was slow and sir. Bet you an mountain. Answer and baby, I bet you an amono. I just when you take a chance. I want my babua. Babua, baby, mine. More. Ha.
At its best. And he says this started from the palace. Ladies and gentlemen, for those who have traveled and joined us, and this is your first experience, anytime you hear Mo, it means well done. And it's just to M-O, Mo. So you can take to the next person by your side and say Mo. Of course, for putting together this great research and papers that today we have the opportunity to launch. Ladies and gentlemen, at this moment, we move into details. I'll not take your time. I'll just bring back again the moderator for the presentations, and I would have Professor David Carlin Ridge come in. He will introduce all the others. Please, let's give him another round of applause as he joins us for the second time.
Many thanks. So we now move to the main part of the programme where we're going to outline the Commission findings. Now, our first speaker this morning is Professor David Kerr from Oxford University. And Professor Kerr is going to give us an overview of the landscape of cancer in this part of the world and the ambitions of the Commission. Professor Kerr.
Good morning, everyone. To my friends in Ghana, Machi, I should say that. Your Excellency, First Lady, Your Excellency Isaac Adivoli, dear friends and colleagues, it's my great privilege to be able to set the scene for the detailed discussion that we'll have later, and also to bring warm words of welcome from the Dreaming Spires of Oxford. We have many links between my university and this wonderful country at every level, and these are links that we would like to strengthen and extend. Next slide, please. So I'd like to talk about what I call amplified good, the benefits that we as practicing clinicians can bring to wonderful nations such as Ghana, but wider Sub-Saharan Africa, by extending the work that we do into public health and policy formation. So each of us who are practicing doctors can do this much good with the individual patients that we see in the clinic. Our research can reach around the world and affect the lives of many thousands of patients. But if we can come together at this moment in time, if we can change health policy in a way that's positive and suggested by the Commission, we'll impact in the lives of hundreds of millions of individuals and citizens positively. And that's the gift that you can give to us. By working collaboratively, with collectivism, with compassion, we can make a difference starting from today. Next slide, please. The amplified good has changed in this way, but we have never, as a global community, been more interconnected. If you think about the geography of this situation, the fact that this important meeting is being streamed online, we have friends and colleagues from around the global oncology community watching and listening to everything that we say. So never more interconnected, socially, geopolitically. So if ever there was a moment in time for us to come together to take a collective approach, we would think that it would be now. Next slide, please. If we take this into the science of our interconnectedness, of the things that keep us the same rather than different, I'd like you all just to take a second to read this slide. Look at the genetics of how we're a large family. Africa is a bath of birth. This is where we come from genetically. Nobody on earth, as we see here, is further removed than your 50th cousin. Think of that. And think about the air that we breathe. Because of the ceaseless movement of the Earth's wind, within a year, each of us will have breathed the atoms of oxygen that have been shared around the world. We are an interconnected community. We stand together or we fall apart. Next slide, please. So, if we think about global healthcare revolutions, then we would map these as follows across the different centuries. First of all, we had public health, understanding about clean water, understanding about sanitation. Then came the second healthcare revolution, which is around the sharing of knowledge. And I know that my African colleagues who are involved in delivering cancer care and research are keen to contribute their knowledge to the global community so that we can share and understand better the biology of cancer, so that by working together, collaborating again, we can help to overcome it. I think we're on the brink of a third healthcare revolution, and if we consider this is when we think of us driving healthcare forward, driven by equity of access, fairness of delivery, and by implementation research, something that David Collingridge mentioned early on, and something which I think Africa in general and Ghana very particularly could be in a very strong place to help drive forward. How do we take the latest innovations in cancer detection, prevention, treatment, but how do we take these into the front line of clinical care? There's a very large gap between the basic and clinical research, and actually delivering that together to the benefit of our patients and citizens. So I think this is going to be an increasingly important area of working together. Next slide, please. This will be stated in greater detail by my colleagues who will be giving more detailed discussions around the findings of the Commission. But this is painting this general approach that if we look at the global cancer burden, collectively it reaches beyond AIDS, TB, malaria, and yet it's been a hidden epidemic, one that is stigmatized, one that people are fearful of discussing, one which is hidden, particularly in some of the villages. The work that Beatrice has been doing, remarkably in her outreach work for early detection of breast cancer. I was a young fellow working with another friend of ours, Twalib Nagomo, 35 years ago in Glasgow, Scotland, my hometown. And Twalib and I were friends then, and I came to do a clinic with him in Dar es Salaam in Tanzania. And 80 to 90% of the patients presented with very advanced disease. Whether these patients were treated in Harvard or Oxford or Corlebu, the results would have been no different because we'd been conquered by the disease. 30 years later, just before lockdown, I was doing another clinic in Dar es Salaam with Twalib, and it was still the same. 80 to 90% of patients presenting with incurable disease. David said earlier that prevention is important, and we could not accentuate that more, as you'll see as we discuss more the findings of the Commission. Next slide, please. This is the next slide will show the projection by WHO, how, although we think cancer is a disease of the north, of the west, of the wealthy, of the industrial, it's not. This is a disease which reaches into every corner of the globe, every village, every home, every family. And this just is a projection of showing that the increasing burden of cancer will be placed in the shoulders of those who at the moment are least well prepared to be able to deal with it. Hence the Commission, and hence the importance of having Her Excellency the First Lady, having the chiefs, having distinguished visitors like yourself, who can bring the voice that we have to amplify it and take it to the common people, to citizens, because that will make a true difference. Next slide, please. So, this is another dear friend of ours, Professor Ala Alwan, who was Director General of WHO, and it was he who put cancer, cardiac disease, diabetes on the map of the World Health Organization. And again, this is important not only for the health minister, but for the finance minister, for the education minister, and it requires joined up government for us to be able to deal with this. This is not a health problem, but it's a collective failure across government. And if we're failing to deal with cancer, we're not supporting the population of citizens that we're here to serve, and nor the economy of this country, particularly true as all of us are emerging post-COVID with each of our own financial difficulties. Next slide, please. So we need to, David said it very well at the beginning, we need to move beyond warm words to hot action. These are a collection of sayings that I have on my wall at home, in saying that the perfect is enemy of the good. We just need to get on with things. We cannot wait for a perfect solution. It will never arrive. We need to strike while the moment's hot. And even if we're just making small, cumulative steps together, I would rather make some false steps together, perhaps make some mistakes, but just to get on, to make a difference, rather than waiting for a solution to come from heaven, which may never arrive, at least not in our lifetimes. Next slide, please. So, the Lancet Oncology Commission and my wonderful colleagues, Beatrice and Will, supported by David in the Lancet, and the extraordinary support of the commissioners who are gathered around this room, have put together a paper which tells you It gives you an outline plan, a framework, something to build on. This is a collective wisdom of some great African leaders, supported globally, underpinned by the Lancet, perhaps the most famous medical journal in the world. And it gives a sense of the direction that we need to take in order to be able to move forward. And what we've tried to do, I think, and I do hope you agree with some success, is to give some clear action points, clear, simple, directional, that would allow us to come together. And although we're launching the Commission today already, David, Will, Beatrice and I are thinking perhaps we'll come back in 3 years' time or 5 years' time to give a report card. It makes us sound like school children, but let's think that the global world, the global oncology community, will engage in our battle together, will help support us, and will allow us to come back, we hope, to see what progress we've made. Next slide, please. So this is the final slide. And of course, it's impossible to be a professor from Oxford and not speak Latin. My university is 900 years old, much older than Harvard. It's important that you know that and understand. Harvard is one of these Johnny-come-lately types of universities that we tolerate. A spin-out from Oxford is the way that we think about it, looking at it that way. So we know that Pliny the Elder said that Africa always brings us something new, and by working with the indefatigable colleagues here, by understanding and studying the biology of cancer in Africa, I will benefit from working together, a true partnership. It's also true, probably Thomas Hobbes said, that knowledge is power. The more we understand, the less frightening, the more we can do together to drive things forward. So again, for my Ghanaian friends, Medasi.
Thank you, David. Fantastic speech as ever, setting the scene. I'm sure many of you are going to have a lot of questions actually once we go through these presentations this morning. If you hold on to your questions, after this session, Professor Rebic will be chairing a Q&A and panel discussion. You'll be able to ask questions at that point. So now I'd like to turn the microphone over to, she needs very little introduction actually, Professor Beatrice Wafayadai, the CEO of Peace and Love Hospitals and founder of Breast Care International in Kumasi. And Dr. Beatrice is going to be talking about registration, reporting, screening and diagnosis.
Good morning, good afternoon, good evening to our viewers globally. This is a warm welcome from Ghana. And I want to thank the chairperson of the occasion, Oja Owonana Yaojibi II, my first lady and our first lady, Her Excellency Ma Rebecca Akufo-Addo, affectionately called by our people, Professor Nana Opoku-Agyeman. Let me stand on all the existing protocols just to acknowledge my fellow lead commissioners and all the commissioners across Africa and the world. So I'm touching on registries, reporting, the importance of reporting and data, screening and diagnosis. I would like to also touch on this lovely quote by Professor David Kell. We call him David of Oxford, and courtesy the Lancet Oncology, that we've seen too many reports, too many words, too many good intentions, too many families torn apart, and too many excruciatingly painful deaths to see yet more delays in taking collective action to accelerate cancer control in Sub-Saharan Africa. This quote says it all. And if you are here with me today, if you are listening to us from across the globe, I'm very sure that you relate to that quote. My next slide, I call is a miserable one for Africa. Kindly look at the red map, which is ours, and look at the figure by rate. So when we talk about population-based cancer registries in the world, we have this pathetic 1% since 2018. I don't know how far we've moved from 1%, but it's nothing to write home about. The growing evidence, based in part on information provided by cancer registries, suggests that most new cancer cases now occur in Africa and the low and middle income countries, increasing from 15% in 1970 to 56% in 2008, and anticipated to reach approximately 70% in 2030. We are in 2022, so 2030 is not far from here. Given these stark realities, there's an urgent need to improve existing registration infrastructure to ensure that high-quality population-based cancer incidence data are consistent and available while initiating sustainable cancer registration models where that is possible. Cancer registration requires adequate resources, and that is what we normally cry about. No resources, but it's something that we must do, and we must do it now. Cancer registry information can have a direct impact on care. For example, it has been used extensively and systematically for the planning of radiotherapy services in the United Kingdom. So it means that we need the information, we need the data. Data collection and data management. A lot of us scientists know that that is an elephant in the room. How to get it out is a problem. And if we don't get it out too, we can't move on. Cancer data collection begins by identifying people with cancer who have been diagnosed or received cancer care in the hospitals, in the outpatient clinics, in the radiology departments, doctors' offices, laboratories, surgical centers, or from other providers, like even pharmacists. All countries need to have laws requiring newly diagnosed cancers to be reported to a central registry. We have a blueprint. We report all maternal health deaths. So we need to start reporting and recording all cancer cases in our country. Which are the categories of cancer registration? The patient demographics. And this will include the patient's name, age, gender, race, ethnicity, and the birthplace. The tumor characteristics, which describes the tumor, the nature, the tumor biology. And now, the genomic information on the tumor, such as specific biomarkers that might predict the outcomes or response to specific therapies. And that is part of the research Professor Ingwa, who is originally from Cameroon. He's our brother and has done a lot in Harvard and Johns Hopkins with the colleagues. And this is something that is innovative. the stage of the disease. We need to know whether it's an early stage or late stage disease, and that will determine the treatment that we should use. The treatment that is given to the patient, for example, surgery, radiation therapy, chemotherapy, hormone therapy, or immunotherapy. And the outcomes is always important. The patient's vital status and the cause of death and the survival time. All these information are important. So the registry portrays like the organized data collection system. I mean, they should be organized, not sporadic, not, you know, I'm doing my own thing, you are doing your own thing kind of thing. The left hand is not talking to the right hand, and those of us in the medical field, we understand this very well. It is happening, but we need to break the barriers. And so the patient information is gathered, de-identified, so we use codes to protect the privacy of the patient. And then we send them into the secure database of a health information center. And this is doable. Let us do it. The importance of cancer registries cannot be overemphasized. In fact, it's the way we can collect the accurate and complete cancer data, which can be used for cancer control. Because if you look at how we are moving and where we are moving to, we need to control cancer in our society. It's necessary for epidemiological research, public health program planning, patient care improvement, and all the activities that will help reduce the burden of cancers. There are three types of registries. The population-based registry, which showed only 1% in Africa. The hospital-based registries, which exist in most hospitals. Maybe they wouldn't be accurate or up to date. And then the pathology registry, which is normally for educational opportunities for those who want to learn about particular types of cancers like breast cancer, prostate cancer, cervical cancers. Who reports into the registry? The healthcare facilities, the hospitals, the outpatient surgery centers, the labs, diagnostic and treatment centers, healthcare practitioners. Cancer data are highly confidential. Therefore, one of the most important responsibilities of cancer registry professionals is to protect the confidentiality of cancer patient information. Not that you inform other colleagues about somebody's diagnosis and they start pointing hands. Already the disease is stigmatized, so we need to protect the identity of the patients. The challenges, and there are huge number of them, a lot of them. The leadership and coordination systems. We need to strengthen dedicated leadership training to align the registry's coordination with national health systems and to enhance stakeholder input, recognition, and feedback mechanisms. If I give you the information, you should also give something back so we know where we are and where we need to move to. Lack of harmonized standards. We need to install harmonized documentation forms for uniform data collection across data sources. Legal framework. We need to create the legal framework supporting cancer registration or the registries. We need to create the legal framework supporting access and conditional use of the registry data, including by third parties, training of staff. We need to start where we haven't started, but maintain international collaboration opportunities for training of staff, especially with the International Agency for Research on Cancers, IAC, and WHO. Some actions have been taken. In 2022, all governments and members of the World Health Organization approved the Global Monitoring Framework on NCDs, which includes a commitment to reduce premature NCDs, including cancer-related deaths, by 25% by 2025. Ladies and gentlemen, 2025 is just across the corner. So is this a mirage? At the 70th World Health Assembly in 2017, governments from around the world adopted an aligned cancer resolution, WHA 70.12, cancer prevention and control in the context of an integrated approach which supports the creation and maintenance of registries. Let me touch a little bit on screening and the challenges. It's estimated that between 30 and 50% of all cancer deaths in the low and middle income countries could be prevented if population screening and early diagnosis could be addressed to ensure patients with curable cancers presented early enough. We are losing a lot of our loved ones. Let's work towards this. One of the key domains to ensure effective treatment is the provision of accurate and timely diagnosis. Despite the advances in cancer care in Sub-Saharan Africa, the shortage in the healthcare workforce and the centralization of specialized personnel impedes the rate of improving the delivery of care. But you know what? With the advancement in telemedicine, we can take advantage of our colleagues in Harvard, in Johns Hopkins, in Oxford, and bring them through the Zoom to train our professionals. They don't need to relocate to Africa. We can't achieve that, but we can benefit from their expertise. Indeed, a timely and accurate cancer diagnosis is compromised by the limited workforce and variation in the balance of skilled healthcare workers. It's estimated that Africa currently requires a 211% increment in radiotherapy workforce to enable equitable access to radiotherapy. How can we catch up? Similar disparities are found in the surgical workforce, radiation and clinical oncologists, with the vast majority in Africa working in North Africa and South Africa. Diagnostics which include pathology, laboratory medicine. We cannot do cancer without pathology services. And these and imaging are crucial components of cancer care. In most Sub-Saharan Africa, efficient histopathology specimen referral systems are lacking due to poor infrastructure. Unregulated laboratory practices result in patients being misdiagnosed with downstream consequences. That's more advanced stage when finally diagnosed. Inequitable access to diagnostic, with most major centers located in the urban areas. And permit me to use Malawi, that only 20% of the population is within a 10-kilometer of healthcare facility. When you come down to Ghana, our pathologists are mostly in the cities. So what's happening to our mothers, sisters, relatives who are in the communities? Long periods of equipment downtime due to inadequate maintenance. And this is so common because of the expenses and the lack of reagents. We hear this almost every day. No reagents. There are practical solutions to the key challenges. Developing sustainable, affordable, and timely pathology laboratory medical services is a multi-layered challenge that requires a combination of established and more innovative approaches. Advocacy for PALM and imaging should be integral components of the cancer care pathway planning, and wherever possible, to leverage the existing infrastructure of successful programs like PEPFAR, HIV/AIDS, malaria, tuberculosis. All these platforms are there. Let's collaborate and use them to the benefit of our cancer patients. The development of population screening as a contributor to early diagnosis remains underdeveloped across most sub-Saharan Africa, except for cervical cancer in some countries. There is a need to re-evaluate traditional approaches to screening and develop innovations that can be customized for the complex populations. Ethno-linguistics, we don't understand each other in the same country, so we have to find a way of reaching out. Migration problems, now we have the urban poor, and we need to also consider those people. But let's look at the practical example. A considerable number of women diagnosed with breast cancer in Africa are less than 40 years old, calling into question most population screening approaches that have been developed in different high-income settings and populations. The lack of funding may not be enough to support widespread national mammographic screening programs for now. I'm talking about now, but it can change tomorrow. Strategies that incorporate breast awareness and equipping health workers with education and skills to perform quality clinical breast examination may have the potential to complement early detection strategies and potentially downstage breast cancers. We have our hands. We have a lot of community-based nurses. We can retrain them so that they will help to identify breast cancer in their communities and refer them to the treatment centers. That is what we can do now. Thank you so much for your attention.
Wonderful. Thank you very much. So our next speaker this morning is Professor Lorna Renner from the University of Ghana School of Korle-Bu Teaching Hospital and here in Accra. So Professor Renner is going to be talking to us about prevention, treatment, palliative care and research.
Thank you. Good morning, ladies and gentlemen. Our chairperson, our dear First Lady, fellow commissioners, all protocol observed. I'll take you through some aspects of this prevention, treatment, palliative care and research that's in the report. So how do I get them to change the slides, please? Yeah, so I'm going to take you through sections 2 to 6 of the report. Right. So as we all know, prevention is always better than cure, and the key to prevention is identifying causes and reducing population exposure where possible. From limited data, we do know that the commonest reasons for cancer in Africa are infectious diseases, use of tobacco, energy imbalance, and alcohol consumption. With regards to infectious diseases, I hope most of you have heard about the human papilloma virus, HPV, and surprisingly, of concern is that over a third of all cervical cancer deaths globally are due to women in sub-Saharan Africa, whereas only 14% of the population of women reside in sub-Saharan Africa. There's a low level of public education on cervical cancer. A study conducted even here in Ghana amongst adolescents showed that over 90% of them had not heard of HPV or the vaccine. And in 2019, only 16 countries in sub-Saharan Africa had rolled out a program to vaccinate against HPV. Next, please. Yes, with regards to hepatitis B, WHO has recommended that all countries should institute a birth dose of hepatitis B vaccine. However, only 11 out of the Sub-Saharan African countries have instituted this. We do know about the problems with smoking. However, there's a low implementation of the framework of Convention on Tobacco Control in Africa, not due to lack of resources, but most likely due to lack of political will. Energy imbalance, in other terms, it's obesity. And it's associated with at least 12 types of cancers. That's really worrying. And adult obesity has increased over the past 30 years, coming to Ghana by over 500%. In places such as Burkina Faso, it's increased by over 1,400%. And this just shows up, there shows smoking tobacco, more prevalent in South African countries, but we shouldn't be complacent. And with regards to obesity, it's more prevalent in those in the wealthier centiles, as you can see, across all the countries sampled. Right, so that's section 2. Section 3 discusses systemic treatment of cancers. And we do know that SDG, Sustainable Development Goal number 3, looks at affordable essential medicines and vaccines by 2030 by all. However, in most of Sub-Saharan Africa, we do know that there's weak infrastructure and problems with inefficient market and procurement practices, leading to people being unable to afford the medications. And fortunately, there's been a harmonization. I think I'll just have to get my laptop because there's nothing showing on the screen, and there's nothing here. Thank you. I hope you'll be able to see the screen later when it does come on. Okay. So, yes, with regards to systemic treatment, that's chemotherapy, there has fortunately been a harmonization of cancer treatment guidelines in Sub-Saharan Africa undertaken by the African Cancer Coalition in partnership with the American Cancer Society and the National Comprehensive Cancer Network. And for childhood cancers, there are adapted treatment guidelines undertaken by the International Society for Pediatric Oncology for childhood cancers in low and middle income countries. When it comes to more specific therapies, it's important, as was stated earlier by Dr. Beatrice Riafi, that we should build capacity in our laboratory services for biomarker testing so that we'll be able to select appropriately the patients who benefit from such specific therapies. We do know that we can administer chemotherapy on outpatient basis, and it could be decentralized, but we need to have a good system of monitoring to make it safe. And then when it comes to innovative treatments, immunotherapies, we do need to think of ways to be able to administer it so that it's not so costly. For example, using smaller amounts of immunotherapy in combination with other treatment modalities. But for this, we would need to undertake multi-center clinical trials in Sub-Saharan Africa. When it comes to surgery, there's a need to expand surgical capacity in Sub-Saharan Africa so that new surgical oncologists are trained in specialized techniques and we improve the skills of the current workshop. However, we should be careful not just to use all the high-income models of training so that we don't risk over-specialization. And we should be able to set up regional and national centers of excellence for surgical specialty training, and there should be accreditation bodies set up either nationally or continentally to ensure that such training centers meet minimum standards.
When it comes to radiotherapy, the data in 2021 show that out of the available 420 radiotherapy machines in service on the continent, more than 80% of them were in Southern and North Africa. Brachytherapy is in short supply, and in the next 15 years, it's estimated that we'll need at least 5,000 additional radiotherapy megavoltage machines to ensure equity in cancer care. So what are the key messages for diagnosis, treatment? That one, essential medicines list should be adopted. All these key messages are in the report, so I'll just mention a few of them. The WHO essential medicines list should be adopted along with the harmonized protocols, and we should leverage regional blocks so that we can negotiate better for better pricing and affordable medicines. We should establish national and regional centers of excellence, and we should ensure that there are continental or regional bodies for accreditation of these centers. Overall, for treatment, patients with cancer should be managed together with multidisciplinary teams. Cost effectiveness is important, and we should ensure that strategies are such that more patients can access treatment rather than expensive treatment for just a few people. Political goodwill is very important, together with universal health coverage that remains essential. We should advocate for government investment in cancer diagnostics, and we should also mobilize advocacy for global funds, for example, as pertains with regards to HIV and TB. Global funds for cancer care is important throughout the cancer continuum. Now for section 4, that covers palliative care. And we do know that palliative care is an essential element of cancer care right from diagnosis to cure or otherwise. And the report recommends the 5S framework to improve access to palliative care in Sub-Saharan Africa. This framework, the 5S's are staffing, that's training, staff or services, ensuring we have drugs, radiotherapy, and other treatments available, the space where we would practice the palliative care, whether it's in the home or in a hospice or a clinic. Systems should be put in place, and synergies as well. That is, palliative care should be integrated so that it's not just a standalone thing, but can work with other specialties as well. Then section 6, when it comes to research, that's really important. And implementation of cancer control and treatment modalities are unlikely to be optimal without research. And we do know that we have unique features in Sub-Saharan Africa with regards to our population and our health system. So all of this should be taken into account in undertaking research. We should expand African cancer research. And we should consider decolonialization of research, as the report states. Interesting to view it that way. And so the activities should prioritize the needs determined by Africans to benefit Africans. When it comes to novel therapeutics, we should expand clinical trials and therapeutics so as we can understand how best to apply these in Sub-Saharan African patients. And unfortunately, the clinical trials in Sub-Saharan Africa, they are limited because of a lack of clinical and regulatory infrastructure, particularly for the early phase trials. As was stated earlier on, all the research, including etiological, translational research, must be complemented by implementation science, which will address social determinants of inequity of access to healthcare and social justice. Our research partnerships must consider implications of the imposition of European and American values and expectations on the African continent. And we do need capacity building and development of Sub-Saharan researchers. So we should try to integrate the training of early career cancer researchers into career development funding that addresses prioritized research goals. So, finally, what are the components of success in cancer research for Sub-Saharan Africa? We have to have good success metrics, achievable and feasible, institutional buy-in, good governance, which is multi-stakeholder involvement. We should leverage existing resources as much as possible. The research would usually benefits when it's in an academic environment. There should be a good supply chain. There should be equitable collaborative research, and all of these points are in the report. And there should be decolonization of research in Sub-Saharan Africa, considering also the local health ecosystem. We should also seek to balance care and research so that we prioritize research that is short-term and that will have both public health and clinical benefits. Thank you very much.
Well done, Professor Renner, for surviving through the lack of screens here. The tech team are working hard to get the screens working again. Hopefully we'll be able to turn to our next theme for this morning, which is looking at the workforce, health systems and infrastructure. And our speaker is Dr. Werner van der Puer, who's from the National Centre of Radiotherapy, Oncology and Nuclear Medicine at the Kolebu Teaching Hospitals here in Accra. And I hope Dr. van der Puer will be able to muddle through without the screens as well. So thank you.
Thank you very much, Professor Collins. I'll try hard to present without a screen. I've done that all my life, but I'll try. So I'm presenting today on health systems, infrastructure, and workforce. So I'm using my phone, innovation. So let's talk about strengthening health systems. We know cancer care is like all non-communicable diseases. It's currently running a chronic course, so our patients are living so much longer. What can we do to avert the morbidities from these diseases? The cost of interventions from surveillance, diagnosis, treatment, supportive care to end of life is prolonged and costly for all. Everywhere in the world, cancer treatment is expensive. We can't avoid that. But we know that the healthcare systems are pivotal to enabling all interventions and coordinated guidelines leading to, and we need effective inputs for these to work out. We know we need the health system strength, we need our communities, and we need our patients to get together to improve outcomes. We learned these from our COVID, that the whole idea was to try and limit exposure. We all came together, we had different approaches globally, but the aim was the same. We all had different approaches. In the same way, we might have different approaches to how we control cancer. But there is a general framework which we all must follow. So I had a beautiful diagram that showed you the different kinds of GDP and compared to the mortality incidence ratio. Unfortunately, for most of us in Africa, we know we have very low health spending budgets. We have a lot of competing interests that everybody understands. Our kids are still learning under schools and our roads are still rough. So it's difficult to ask us to concentrate everything on cancer, and we who live in Africa actually do understand that. All the same, we've seen what all the economics showed us, and we know that when we have low GDP in terms of our health spending budgets, our cancer incidence and mortalities are so much higher. But on average, some countries actually, even though they have low GDPs, they actually do better than the rest of us who have very little GDPs, and vice versa. Some people with even a higher GDP are doing worse than those who have low GDPs. So we all have to see that the economics of cancer care is not just about what you earn, but how much you put in. And there's also another beautiful table that tells you about the economic impact of cancer. We all take it for granted that cancer is nothing. For many years, it wasn't even in our textbooks in the medical school. But now we all know how important cancer care actually affects the economic growth of our countries as well. Sorry, the phone went off. Okay. So I also like to talk about the spectrum of health systems for cancer control. We need to have, starting from the primary care level, we need to have referral patterns. What happens to our patients? Unfortunately, at the primary care level, we might not even have doctors, but we need to actually educate these health workforce in these levels to identify or suspect cancers and lead them along the way to get to their treatments. We need to educate our workforce, not just specialists, like we said, but also even the general workforce, even the community health workers. And I think that is the way to do it. To be the high index of suspicion is what is missing. We also need to talk about governance, legal framework, you heard a lot of that, and also about administrative processes. Unfortunately, most of our administrative processes don't end up in implementation. We keep saying implementation. We all have the same language. I'm sure you've all noticed that. But it's about implementing what we have thought should be the best thing to do. We also have to talk about equipment, logistics. A lot has been said about that already. This is just a typical example. It's very difficult to have high-end radiotherapy machines when your lights go out every few minutes. So these are some of our challenges. But I think for those of us who've been working in Africa for so long, things have gotten so much better compared to what they were a decade ago. Like Ghana has moved so much forward in terms of our cancer control. We want more, but we understand the situation. But I think that people can learn from what other economies have put in. Rwanda is a very good example, but then it's a very small country with a lot of external support. So probably that's why we tend to use them a lot as examples in pushing forward their healthcare systems in terms of universal health care, in terms of community spirit, in terms of the quality of care and decentralization of care. And even with the HPV vaccination, they are one of the few countries that have attained almost 100% immunizing their young women. But we haven't developed that yet because it's a small country. But we can learn from these structures and actually improve what we do in Africa. I think, unfortunately, like you said, only 16 countries have rolled out immunization. I think Gavi has come down with the cost of immunizing our women to $1 per vaccine. It's much cheaper than the $20,000 you are going to spend on treatments. So it's something for economies of scale. We need to think about what these things are going to translate into down the line. So I also like to talk about logistics. We talked about that. We have the equipment, but then we don't have the logistics. We're always running out of support systems. We're always almost running out of reagents, and these are important. Cancer is very scientifically it's advancing, as somebody said, just like how the apps on your phones are adapting. It's the same with oncology. We need to update, and the patients are living so much longer. And why are they living longer? We need to translate that in our daily practices. But a lot more goes into it, and that's all about infrastructure. Our research systems, Professor Lorna talked about that. I'm not going to go that much into it, but we all suffer as researchers in Africa. We know what the limitations are, but a lot more we can do for our government to support us to promote research, because without data, you really can't plan your treatments. You can't plan your infrastructure. You need to know how do we know that breast mammography is not good for Africa? There are a lot of tiny studies, but we don't have large studies to show that maybe mammogram is not what we need, but rather we need breast palpation by even the community health worker. It's as simple as that, but we don't have the data to support it. These are some of the things that we need in Africa. Then we also have, I think Sudan has very good examples. I want you to read the document, so I'm not giving specifics, but I want you to go back and read the document. And also the quality of life of our patients also has to do a lot of systems down the line, the healthcare systems. What are they doing to support our patients through survivorship and even towards the end of life? You might have a cancer patient, but you should be able to have a full potential to the growth of your economy. So you need to support them with the systems. So how much does Africa invest in health in health systems? That's the question we need to ask ourselves. The data actually showed us that not much, but we all understand the reasons why we don't have that much money. But again, like I said, it's not an excuse. It's about prioritization, and we need the data for that. How many of us have universal health care? Very few of us, unfortunately, but I think it's one of the SDG goals, and we hope to get there eventually. Ghana has started with some healthcare coverage, and I'm glad to see the children on board, because that was a really big problem, because the children are our future. We have a lot for the women, but also the men also need some attention. And the reasons why most people in Africa don't come for their treatment is mainly the financial toxicity, because it costs a lot of money. It doesn't change anywhere. The treatment, the drugs come from the same place. Of course, it will get cheaper if the drugs were made in Africa, and that's something to look at. And I'm going to talk about other models of this as well. We also need timely intervention. Again, we know that the time to presenting to the hospital it's a factor on how outcomes are. But if you look at different countries, Kenya has a lot of, they've expanded a lot with their cancer care in terms of universal coverage, in terms of decentralizing their health systems for cancer. So therefore, the patients pay less out of pocket. They have to travel less distances, so they are more willing to go for their cancer treatments. And Rwanda, again, is doing better. Tanzania is doing better. North and South Africa always have more money than we do. So they seem to, but we can learn from these people and from our other. So Africans need to get together to come out with a framework to improve on cancer care. I'm still not up yet. Okay. So we need to also increase what is the quality of the cancer treatments we have in Africa. We do a lot of short-term planning, and I think that needs to change. Our workforce has to be skilled, and we have to train properly. It takes like 7 years to train an oncologist. For many years, we didn't have pediatric oncology, we just had 2 or 3. It's getting so much better. I am with the African Organizations for Research and Treatment in Cancer. We network a lot with cancer organizations and even individuals. And we can see the vast increment in the number of oncologists on the country, the number of basic scientists from Africa, a number of palliative care physicians. It is getting so much better. But the cancer landscape is going so much fast that we are not catching up. So we need to quadruple our efforts. We are moving forward, but we need to quadruple our efforts to be able to catch up with the impending doom that is due to us. How many of us have dedicated secretariats to fight cancer? And then we talked about registries. I won't talk about that. We all start from the basic care level, but most of these levels actually don't have oncologists or specialists to help with that. But we can harness on interventions like artificial intelligence, telehealth. I think these need to be part of our infrastructure from the Ministry of Health to help to make these better. We also have very few cancer hospitals, but that's a model not really for Africa. We have the teaching hospitals that have most of the cancer facilities. Unfortunately, there are not too many, but cost is always the problem. But we have to harness ways of hub and spoke models to be able to improve cancer and cover the countries better. Most of our, unfortunately, our ecosystems, like Dr. Lorena said, most of us are underfunded, but we need to do a little bit more. It's about prioritization. A lot of progress, like I said, but we're still lagging behind. We need to, unfortunately, most of what we do is determined by our development partners, and they have their own priorities. But they also don't look at the cultural aspect. There was a study recently from Joko Fro, just published a few months ago, that showed that even in countries that had universal health care, and they had radiotherapy service, all the frills that come with it, the women did not go for treatment. Only a quarter of the women completed their treatments. Another 1/3 no show. And another 10% refused to come for the treatment. So these patients actually have the facilities, and yet they didn't come. So the reasons is the behavior. We are not doing a lot of anthropology research to find out why our people are not coming for treatment. Why are we not educating our women? If you educate a woman, you educate a nation. I think we need to invest more in that, starting from our girls. Yes. We are failing to commit to cancer at the basic care level. We need to look at the private sector. I think they have a lot to offer because we know that the government can't cover all because they have a lot of other problems to do. Workforce training is important. We need to look at our funding models and again look at the stakeholder engagement. So most of the decisions are not made by the people, the end users, and I think this has to change as well. We know that we have, we just talked about the WHA 7012 and how we need to commit. Only 18 out of the 25 registries actually have update reliable data. So we need to put more into the cancer registry. Data is the life of planning. So we need to have that data. It's very important, and the quality is also important. We need it to drive our, coordinate our systems. We need to show the success stories. Why Ghana doesn't come up so much, even though we do so much, is that we don't even have the data out there to show what we do in Ghana. So that's why people don't, but we really do a lot. And we are a model for international training in Africa. So people need to know that, but then there's no data out there. People don't even know this. Look at our vaccination programs. Again, like I said, with HPV, we have Tanzania. Most of the people who have taken up HPV vaccination are in the south and in the east of Africa, and very few in the west of Africa. The question is why. But we all know we have a problem. I think COVID showed us all that we have a problem with vaccination, and it's purely cultural. Even the highly educated actually have problems with vaccination for so many other reasons. So how do we educate ourselves to make sure this actually also improves? Healthcare financing is a big problem. I've said that over and over again. Out-of-pocket payments, it's not just with the cancer care, but there are so many social issues that come along. transportation, where to live. It also comes with decentralization of cancer care, but it has to be a safe decentralization. We should remember that. It has to be safe, not just providing the drug, but all the systems have to be available, including the supervision. Turnaround time, like I said, is a prognostic factor. How do we make sure the patients go for the treatments? We know that cancer is the biggest cause of bankruptcy, even in the high to income countries, and for us it's even worse. It trickles down into families. The ladies, the children are not able to go to school. They are not able to fund their businesses because they have to pay for a patient with cancer in their family. So we really need to look into that. Competing interests, we know that is a setback, but we need to have to work around it. So we need to look at pooled procurement, like Lorna said, for our medications. The medications are expensive. We need to talk about even manufacturing locally, like what India does, and compulsory licensing. We need to look at private partnerships. She's given examples of the Clinton Access that is working in other countries, Tanzania, Rwanda, again, Nigeria. We need to copy those, and it's coming into Ghana. I think it's something that should be embraced in the aim of reducing the cost of drugs. We need to have a tiered approach. We know that we can't just absorb all of it, but what are our priorities? And that is exactly what we need this data for, and the infrastructure to build up this data. And we need to harness information technology to help us to manage better. We need to also include preventive and screening services in our universal healthcare coverage. Most of that is missing. So before you get diagnosed with cancer, the treatment is covered. But what about the mammography? What about the screening? What about the pathology? We've talked about that already. I think that needs to be, and then we need to have realistic payment models. So some of us have universal health coverage, but the amount of money that is reimbursed does not run the system. So of course, you have an infrastructure collapse. So I think our governments needs to be sensitized of that. In terms of workforce challenges, I don't really need to talk a lot about that. Other people, but we have a great limitation. We recently did an update on clinical workforce for cancer, and we have a lot of limitations. We have one of the biggest burdens for our oncologists across board: gynae oncologists, pediatric oncologists, palliative care, all of it. And some of them are actually now developing. And the workload is heavy. Of course, we can talk about tax shifting, but it's about educating the whole workforce. Then it's easier to tax shift. Like I said, it has to be a safe decentralization as well. But we need to strategize, we need to invest, and we need to prioritize from the data that we collected from our Lancet Commission. I think I want you to read this so you can come up with the good examples that we have. We will not be able to realize our SDG goals without universal health coverage. We see it as a big problem. I think we need to learn from South Africa, North Africa, and East Africa have done very well with universal health coverage for cancer care. And these are models that we can get. In terms of the skilled workforce, again, Dr. Elona has said a lot about that. Low enumeration, it makes us liable to brain drain. Very attractive ones as well, because we are actually very highly knowledgeable and highly skilled and able to adapt even in low income conditions and high income conditions. So it makes us very attractive for people to come for us. But I think the enumeration and all that is what keeps us away. And then also the emotional burden. So we know a lot of people don't want to do oncology because of the emotional burden, but we don't have enough psychologists. I think they will take over that. So we have a lot to do with the skilled workforce, not just clinical oncology. That's just the tip of the iceberg. There are so many other people that need to be trained to be able to move this. And always don't forget the basic scientists that help us to determine how we make our treatments. Because it might be different in Africa. We have a lot of examples where certain drugs that are written in the guidelines don't work for Africa, or they have too much toxicity, but we are not developing this data because we don't have the infrastructure to do this research locally. We just adapt from like a cut and paste approach. So I think we need to do more in terms of our research, infrastructure. So what we need to do, like somebody said, is to talk about local curriculum. We need to invest in Africa. It has to be Afrocentric because we have our own specifics. We have our cultural limitations as to why we don't go for treatments. We don't believe in screening for a disease that hasn't manifest. You're looking for trouble. That's what we all say. And I said it's starting from even the highest educated person, believe me. So we have a lot. The culture is in our DNA. And how do we actually harness that and help to develop platforms and change the way we think. So a lot, in some way, cancer care infrastructure in South Africa has improved, in Sub-Saharan Africa has improved over the years, and I'm a witness to that. But we still have several competing interests. More governments are showing commitment, and we have shown that, but we need to quadruple our efforts to catch up with what is impending. And we can only achieve this with evidence drawn from data. We need to strengthen our health systems, infrastructure, and workforce. We need a unified framework, and we need to learn from each other quite frequently. Thank you very much.
Many thanks, Dr. Werner. We're going to take a few minutes interlude, just so we can get these.
On behalf of the World Health Organization and the Global Breast Cancer Initiative, I'd like to again congratulate you and thank you for this marvelous opportunity. Bravo.
Calls to action, I actually want to first start by recognizing the work of the First Lady. Let's applaud that. 2 years ago, we actually wanted to invite her to Harvard, and I looked on the internet to see what work she's been doing around cancer. There was some work, but recently, when I was talking to my sister Beatrice about inviting her again to the United States, and then I looked on the internet, I was amazed at the work that she's been doing to support Ghana. Childhood cancers, working with Breast Care International, to advocate and support, the fight against breast cancer and other cancers, and building the infrastructure. And I want to emphasize that as much as this commission talks about, the crisis, emergency in Africa, they are really good examples, like what she's doing. We've talked about Rwanda, we've talked about other parts of Africa, that we can emulate and scale across Africa. And so we want to recognize that. And obviously, the Honorable Minister, some of these calls to action, we hope that, like we said, too many painful deaths, that though Ghana has been making progress, there's not a chance to actually increase on that, amplify that. And I want to mention to the President of the National House of Chiefs, we really need these calls to action amplified in the communities. That's why you're here. You are so important to this fight. We have 8 calls to action, very important. And I'm going to start by introducing our distinguished colleagues. And I just want to say, this is probably, and David, you can correct me if I'm wrong, the largest list of commissioners on a Lancet Oncology Commission. 54 of the world-leading cancer leaders, policymakers, who came together to really say, we are going to detail, as you've heard from my previous colleagues, the situation of cancer in Africa, but we are then going to recommend calls to action. What can we do? And so I have with us today 3 of the distinguished colleagues who has worked on this commission, and they're going to read out the commissions for you. First, my dear friend Suma Mohammed. She's originally from Sudan, and she's a professor at Purdue University, and she's going to read the first 2 calls to action.
Thank you, Professor. Yeah, as Will said, I'm honored to be here and originally from Sudan. And when I see you and I see your first lady here, all I'm thinking about is I wish one day we'll have a good government in Sudan, and I wish that we will have one day a first lady like you that take care of cancer. So the first march that we're going to give to African government is to precision cancer control planning. That is the first action. We know that most African government have signed the cancer control plan, and they have a good will to fix cancer in Africa. But that will is not followed by investment. So we would like them, to update their will, to invest again into cancer control and put it in action, and not just to say we have it and we sign for it. We understand we have other priorities, but cancer is also important. And so we are looking for implementing cancer control, not just signing it, implementing it within 5 years. So the second call of action is improving data acquisition and cancer registration. And I add to what Professor Renner and my friend Beatrice and Werner said, that it's very important to invest on cancer registries. Cancer registries is not only important for knowing the number of cancer, but it is important in telling us where to invest. So, like if we know that cancer of esophageal cancer is more into the eastern side of Africa, so these people need to think about how to invest on esophageal cancer, while liver cancer is mostly in West Africa, so maybe we need to invest more in vaccination. So that is why it is important, in addition to the number of cancer, or what cancer is prevalent in which country. And I pass the thing to my other colleague.
Thank you, Suma. So the next two calls to actions are going to be read by my dear friend, Stephen Avery. He is a professor at UPenn, University of Pennsylvania. I call him my African brother because, as Tim Rebeck would tell you, if you do the research, there's a lot of similarities between African Americans and African Africans. As you know, right here in Ghana, when the slaves left and went to the United States, those are our brothers who left some time ago. And so he's going to talk about two of the calls to action.
I think I'm next, sorry.
Oh, okay. Yeah, so correction. Actually, the next person is going to be my brother, Kingsley. So he is a professor at the University of Washington. Originally, he's from Nigeria. So he's been working really hard to build international partnerships to support cancer care in Nigeria. So Kingsley, thanks for the correction.
Thank you so much, Will. Good morning, everyone. It's really an honor to be here. And these call to actions, even though they have been distilled to these 10 points, it's been work that has been done by 54 commissioners over 2 years. And I just want to take this opportunity to recognize them. I'm sure some of them are watching online. And to thank them for the incredible work and to thank Will for his exceptional leadership. The third call to action is designing healthcare systems that promotes equity to access. We've heard words like financial toxicity. We've heard words like catastrophic healthcare spending. In Africa, we have a huge out-of-pocket healthcare spending, anywhere between 46 to 78%. And this must change. How can we change it? We can harness funds from tobacco taxes. We can pool procurements from regional blocks in Africa, things like drugs. Instead of Nigeria to purchase drugs on its own, we can walk through the ECOWAS system to purchase drugs in bulk to reduce the cost. We can look at things like local manufacturing, scale down the cost of cancer care and increase revenues where we can. Every African government should be thinking of reaching the 15% from the Abuja Declaration
and channeling that to cancer. One of my mentors will say, Corey Casper, geographical location shouldn't be the determinant to live or die from cancer. And we can start changing that now by channeling the right financing and including cancer coverage in universal healthcare coverage. The second or the fourth call to action is increasing access to cure and improving care. And today I'm really delighted to see that we have the Ghana Council of Chiefs here. They're a critical, important factor to really bringing the populace to accessing these services. Long before democracy came into Africa, these were the bastions of leadership in Africa, and they still are. And I would like to take a special moment to recognize them because they're the closest to the people. And I didn't tell Will about this, but I would like everyone to please stand up and give a round of applause to this Council of Chiefs that are here. This wouldn't have been imagined like 10 years ago. And the second person I want to mention here is the First Lady. The First Lady of Ghana being here is really a powerful voice. We have African First Ladies coming together, and every one of you who knows about African First Ladies, we see them as the mother of the nation. And you know when your mother tells you to do something, you got to do it because you could get spanked. And so we really want to thank the First Lady for being here because they help to amplify the voice across Africa, to have patients know that it's not when they see a lump that they should go check. These services that are available should be utilized. And we have to change that percentage of late-stage diagnosis, which ranges between anywhere from 65 to 92% late stage. We have to downstage cancers because that is the only way we can improve outcomes for cancer patients. And any way we can do that, whether through telemedicine, increasing access to drugs through public and private partnerships, we should do that. And I think the third set of people I want to recognize here, I mean, everyone here is very important, but the third set of people I want to recognize here is the policymakers. The Minister of Health is here, the former Minister of Health from Nigeria is here. There has to be a bridge between the policymakers making the statements and the people. And I think the traditional leaders, the First Ladies and the policymakers have to work together so that this message can be amplified to the people and increase access to services, both preventive services, early detection, and treatment. Thank you very much, and again, it's an honor to be here, and I look forward to seeing the next 10 years with significant improvements and having geography not to be a determinant whether an African will live or die from cancer. Thank you.
Thank you very much, Kingsley. So now I'm my African brother from the United States. Over to you.
First of all, I would like to say that I'm so fortunate to be standing here with all of you today to participate in this event. I know maybe about 8 years ago when I first started to be involved in global health, I was this young person, stepped off a plane in Dar es Salaam. Let's see what's going to happen here. And 8 years later, I have a new family. I think that, anytime that I need something or want something, I can call Verna, I can call, any of my other friends, and they're right there. And to me, that's family, and that's what this is really about. And so that's why I'm so passionate, and I'm so happy to be here. I thank the First Lady for all you've done and all you will continue to do. And so for Action 5, we know that a lot of cancers that present are late stage. And late stage cancers usually could be, they're already very difficult for the family, but it's also going to be very, very painful. And the management is something that, is unnecessary because we have the care management that's available. And so in the Action 5, we want to make sure that everyone has equal access to management and to care so that the course of treatment and the course of the disease that they are going through is something that no one has to suffer unnecessarily. And so we hope in the time frame of 1 to 3 years that we can have an effective palliation program for anyone who is suffering from disease. Action 6, we heard a lot about building and maintaining the workforce. And we know that cancer is not just about scientists and physicists, it's about the whole community. It involves all of us. It involves the policymakers, it involves the administrators. And so we want to make sure that everyone who is involved in this has the necessary training. For the professionals, we want to make sure that it's recognized. For example, for medical physics, less than 10% of countries recognize medical physics as a profession. And that's an issue in building capacity, and so we need to address that. We also want to make sure that regardless of where you're trained, what country you're trained in, that it's equal across the board. And so we want to make sure that if you're trained in Nigeria, you're receiving the same training as in Dar es Salaam as in Kenya. And also we need to, again, involve the community, the religious leaders, because those are the people who are doing the work on the ground in the community. We want to turn brain drain into brain gain. We know that some people may leave the country, but we still can use that knowledge that we can bring back in other ways. I think the pandemic has taught us that we can do a lot of things virtually. There's a lot of tools now where we can do virtual education, where you don't have to actually be on the continent in order to do the effective training. So we need to use these technologies as part of building the workforce. And we need to establish pipeline programs. We don't have to wait until you're at the university. We should start from the high schools. So let people know, these are opportunities, and how do you actually get into this field? Because these pipeline programs are going to keep the workforce maintained and establish, a consistent number. So we hope that we can continue to build the workforce in 3 to 5 years. And while we do that, I think we also want to implement technologies that can streamline the clinical workflow. Again, this is another way of addressing the issue while we're building capacity, because it will take time, but while we're doing that, we have to address the issues right now. So I will pass it back to Will. Thank you.
Thank you, Stephen. So I have 2 more calls to action. Then action number 7 is innovation and research. And I want to point out that this is really critical. This section was put together by my colleague, Professor Tim Rebeck at Harvard, and a brilliant set of scientists across Africa. And the focus here is to kind of highlight that, Africa has the Einsteins. We're all brilliant. There are very brilliant people here in Africa. And we should be innovating. Like Werner said at the beginning, at some point, the Afrocentricness of this means that we have to empower scientists in Africa, innovation in Africa, to do things that can really meet our own needs. And so the recommendation is that you should establish national cancer research institutes, some budget from at the national level to supporting research. And then building international partnerships. And so, when the program that I actually direct, a Global Health Catalyst, one of the things we're doing is trying to build these kind of international partnerships. And we've had some really good examples where, you can actually mobilize these international partnerships to support these centers of excellence in Africa. And so we think the time frame for this should be within 1 to 3 years. And then the last call to action is investing in telehealth. We have seen during the COVID-19 period that because of the restrictions, a lot of people had to move to telehealth. And so there's a saying that I read somewhere in the NIH website that in Africa, people may not have toilets, but they have mobile phones. We all have WhatsApp, right? We have this technology. So you have an opportunity to reach these people in different communities. My mom in Cameroon, she's very savvy with WhatsApp. I can send her text messages, and she can respond right away. So as we talk about cancer screening and prevention, we can really leverage these technologies in Africa, telehealth. And I actually want to recognize Kingsley. He started a business to kind of really bring telemedicine and artificial intelligence to Africa. And this is something that we should really invest in more, expanding the use of digital health solutions to address the growing cancer burden and disparities. And we think that this is something that Africa can actually lead in. We can really leapfrog. We don't want to go through the same steps that United States or Europe went through. You know, we didn't have landlines, but we can jump right into mobile phones. And we can really reach communities that we would probably not reach 2 years ago or 10 years ago. So we think that it's a time frame here of 1 to 3 years to actually implement these calls to action. And so I want to end again by saying, you know, we have seen too many reports. It's time now for call to urgent action. Thank you very much for listening.
Well, many thanks, Professor Nguyen and colleagues. I think over the last 60 minutes or so, you've seen a really good summary of the Commission and the recommendations and call for action. We're going to have an opportunity to put questions to the panelists and to the speakers in the panel discussion that Professor Reddick's going to moderate in a few moments' time. But can I just end this session and ask you all to give another round of applause to all our fantastic speakers this morning.
Thank you so much, Prof. David. We're grateful for moderating this section. Indeed, ladies and gentlemen, we would get the opportunity to put some questions through, and I'll need that wonderful setup here so that they will sit and feel comfortable. While we prepare to arrange that, I would again humbly call on Lady Akosue Japan to come in and then help me entertain you while I set up. I have full sound engineers supporting you with good backing, so it would not be a solo. Let's give her another round of applause, please.
Baby
Thank you.
You can only do this for Akosie Japan. Please, let's celebrate her once again. A breast cancer advocate, an entertainer, and one of Ghana's celebrated and finest musicians. All right, ladies and gentlemen, so at this point, I'd want to humbly welcome our moderator, Timothy Rebex. Timothy, when he comes in, would introduce the speakers. One thing I'm told is that the speakers will sit by their flag. So, Timothy, if you're in tune with that.
All set?
All right, all set.
Oh, over here, but I'm supposed to sit next to my flag.
Man is committed to his flag.
Yeah, welcome everybody. What an amazing set of presentations and performances, and we're very happy to have our honored guests here today. What we'd like to do now in the next few minutes is talk about a little bit about what we've learned, what we've heard today, and where this can go at this very auspicious day. So we have a few people in the audience who are going to join us. The first person you've already heard is Professor David Kerr from Oxford. Welcome. Our second panelist is Dr. Beatrice Uafe, who you all very well. I'd like to welcome up Professor Will Ngwa, who you also know, have just heard. Our next panelist is Professor Isaac Adewole, the prior Minister of Health of Nigeria. And I believe our final panelist is Reverend Professor Frimpong Manso, who has been the General Superintendent of the Assemblies of God and the President of the Ghana Pentecostal and Charismatic Council. So we're very glad to have everybody here. And so we're going to just have a conversation, and we'd also like to hear from the people in this audience who may have questions, may have comments. We're very glad to take any of those if we can, and we'll also ask the moderator to tell us when it's time to go, so we know. Wonderful. So let me start with a few questions, just as an informal discussion. I'd like to start with Reverend Professor Manso. Because you bring a very different perspective than we've heard today. The perspective you bring is from the faith-based community, from the people of Ghana, and I think it would be useful for this audience to hear a little bit about your perspective and your community's perspective on cancer, how we can think about making this real for people's lives. Thoughts?
Thank you very much. I'm very grateful to be given opportunity to be part of this panel. In the Word of God, we read that Jesus came to heal the sick, to make people free. A healthy people makes a healthy nation. But many people have misread the Bible. They believe that we should be well, but only through prayer. And that has caused a lot of disaster. When COVID, was, devastating our world, we were praying for a cure, but I was praying for vaccines. And when we discovered the vaccine, I was among the first people the president invited, together with the First Lady, for us to go to 37 to have it. And we have to battle to tell the world that the vaccine is safe and we need to, rush for it. So from my perspective, people have been preaching and teaching, misleading people about medical science. That has been the problem. Normally, I share with Sister Beatrice about her crisis, and sometimes she will call me. We've seen somebody dying with cancer. We can help, but the person will not come. Sometimes people even want to donate. So my perspective is that God sanctions medical science. Doctors are mentioned in the Bible. They are using the things that God has created to heal people. Breast cancer or other forms of cancers are real. We need to do three things: early detection, and of course, treatment and prevention. So we should do whatever we could to prevent it, but at the same time, we should take screenings, mammographs, and all those things very, very seriously and regularly. And if there is a recommendation for healing, let us not go to prayer camps for people to prophesy, anoint oils, and tell us all kinds of stories and get us killed. In fact, this is murder. I would say that pastors who are shielding people, especially women and other people, praying and putting oil and doing all these things, you are murderers. Let us give opportunity for medical science to help our world. Thank you, sir.
Thank you. What a powerful message, and an important one for people to understand that they have a power over their cancer, they have power over their lives, and they should empower themselves through their faith or by whatever means, but not to exclude medical science. So it's a really powerful and important message. And I'd like to follow up on that a little bit with Dr. Beatrice, because you have been very involved in the advocacy in the community. You founded and led organizations that bring education and awareness. Maybe you could amplify on what we just heard about how your work and the work of your colleagues in cancer advocacy can really help people take charge of their lives, make better choices, etc.
Thank you so much, Tim. What Reverend Professor Frimpong Marso said is indeed the stark reality, is the truth. And our women are dying needlessly, prematurely, from a disease that is curable, that is treatable. And it's because of the belief we have in our pastors. The Ghanaian is very superstitious. We are very religious. So even when a doctor is speaking and a pastor is speaking to the other ear, she will listen to the pastor's word. And so we need to do a lot of work. We've been doing some work in the communities, but we are not done yet. We are so thankful when we have people like the First Lady, the First Gentleman of the land, the President, former presidents, joining us in creating awareness in the country. But that is the way to go. Our people need to be educated. And we think that educating the youth should be a priority for us, the school children. Because if we educate them well, then we may not need to educate adults. But of course, we have a lot of adult population who cannot read nor write. So we need to send the message to them in the language that they understand and dispel the myths and the misconceptions. We can only do this through a concerted effort, strategically, moving from one place to the other and collectively educate the population. It takes time for people to change their attitude. Sometimes I'm tempted to say that my generation, the generation before me, we should all move out and allow the young ones to come and change the narrative for us. They have the mobile phones. They can Google for information. They will not believe that breast cancer is caused by witchcraft. And so if we have the next generation understanding this, they will help us to educate their mothers, their aunties, their grandmothers. And that is the way we can go.
Thank you, yes. Such an important, yeah, thank you. Very important words, very important sentiments that we've heard from perspectives of the community, from the faith-based community, and how we can begin to educate and advocate for better understanding and knowledge of cancer and cancer prevention. Wonderful. And the other area that I think we heard today that's also critically important is that we have the ear and the education of our policymakers, of the people in our government. So the people elect our representatives, but we don't always have an understanding of how we can make policy change. So I'd like to ask Professor Adewole, who's served as the Honorable Minister of Health in Nigeria. And he has had a lot of experience. I don't mean to raise this and cause PTSD in you from having lived through this, but I think that your experience in trying to manage health systems, resources, funding to address some of the questions that we've heard about today would be really interesting for the group to hear. Can you give any insights as your tenure as the Minister of Health and what we can learn from that in order to make the situation better?
Thank you so much, Tim. It's a great honor for me to be here today, and I want to sincerely appreciate the First Lady for gracing this occasion, and also the President of the Council of Chiefs. I also want to appreciate the presence of my brother, the Minister of Health. It's quite a tough job. What we've done as commissioners is just the beginning. What we've done is to bring a sharp focus on the problem of cancer in Africa, particularly the inequity gap. A friend of mine once said that what is typical of cancer in Africa are three things. And he said the first is late presentation, the second is late presentation, and the third is again late presentation. Yeah. In other words, we need to change the narrative. But what we've done is not enough to change the narrative. We need to speak to the heads of government, and this is where the First Lady is important. The health minister can only go a little distance, but not too far. From my personal experience, you can speak all the grammar. If you do not have the buy-in of the Minister of Finance, you are nowhere. You can talk about people who are dying. The Minister of Works and Transport will tell you people are also dying on the highway. If you tell them people are dying, the Minister of Water will tell you there is no water. And the Minister of Defense will tell you there's an insurgency somewhere. But you need the Minister of Finance. And it is important that you partner with the Minister of Finance to ensure that you have an access to finance. Without money, you can't do far. But particularly in Africa, the First Lady is important. This First Lady can whisper to both ears of the President. In Nigeria, the first thing we did was to commission a cancer center at the National Hospital in Abuja. I got someone who was one of my mentees in the university to say, look, I'm now working in one of their companies. Said, what can I do for you? I said, give me a LINAC machine. And he was able to get me a LINAC machine. But then we needed to commission it, and I wanted to, and through the grapevine, I learned that the mother of one of the top persons actually died from cancer. So I invited her, that's a wife, to come and commission the cancer center. So we needed such narratives to make a difference and make statements. Your Excellency, please speak to the ears of Mr. President and by extension to other heads of government, particularly at the African Union level, because that is where the decisions are made. head minister, finance minister can make propositions. The head of government, the Mr. President, will take the final decision. We need funding. And my advice to my brother, the health minister, is also to speak about health, that investing in health is also an investment in development. It is not an item of expenditure. We need to talk about gains, return on investment. And what I enjoyed doing was to tell them that if we invest $1 in family planning, the return on investment is about $18. You invest in cancer, huge returns, in anti-TB program. So let's talk about return on investment. It costs less than $5 to prevent cervical cancer. But with $2,000 in your pocket, you cannot treat cervical cancer. So what do you gain when you invest in prevention is huge. And what you lose if you don't invest is also huge. So we need to talk about what we will lose if we fail to invest. So there is need for investment. There is need to have a budget line for cancer and have a cancer unit. It is not enough to speak about cancer, but do we have a cancer unit? And do we have budget for cancer? First lady, please talk to other first ladies. Let there be a vote for cancer. When there is money for cancer, I think we should stop begging. We've begged for too long in Africa. And Africa is the richest continent in the world. If we spend less money on buying ammunition and all these things, we will have money for development. Let the guns go silent in Africa. And when they go silent, there will be money for other things. And my advice, talk to Minister of Finance, a cancer unit, a budget line for cancer, more investment in cancer, and that we will gain a lot because there will be money for other things. That would be my advice. But it's not a simple task. Yeah. I wish you luck. Now that you're on seat.
Very, very wise and experienced words from Professor Adewole. And I think that you heard earlier that cancer deaths are going to double in Sub-Saharan Africa in the coming decades. And so what Professor Adewole just said to us is that we need to invest, and we need to invest now because we can't wait until we have a crisis, a pandemic of cancer in our midst. We have to think now well in advance so that we are prepared for the future onslaught that you heard about today. And one of the ways I think we can be prepared for that future onslaught and invest is through research. And you heard a lot about the research activities that are going on. I wanted to ask Professor Ngwa about some of the research activities, because he's been very active, as many of you know, in building novel research activities in Africa. And I wanted to ask you specifically about maybe some of the work that can be done in Africa for Africans by Africans. And an example that you may want to raise is the hypofractionation in prostate cancer, something that would be an approach that would help both the economic and the health considerations for cancer treatment. But tell me about research and how we can make the research benefit Africans.
Thank you, Tim. Yeah, I mean, that's really a very important part. Let me just say, when I was born in Cameroon, and I was growing up in the village, usually barefooted, running, playing soccer, you know, one of the things that always caught my mind, I read a book about Albert Einstein, you know, who was voted, you know, the most intelligent man of the 20th century. And I thought, you know, people revere him, but I actually think in Africa we do have Einsteins. The problem is people just don't know because they don't have the opportunity. You know, actually Einstein is a good example because I remember there's a story about how, you know, the high school teacher thought he was a fool because he was always bored in class, you know, and was distracted and stuff like that. And nobody gave him that opportunity. But once they gave him the opportunity, now the innovation that he created changed the world. And I think that that's what needs to happen in Africa. There are lots of Einsteins here. We need to invest, to give them the chance, the opportunity to innovate local solutions, Afrocentric solutions. Like Tim mentioned, so one of the things that we've learned from the COVID-19 period is that there are things, you know, we talk about a cancer moonshot in the United States, I work with my friend Melvin Foote, to kind of engage the U.S. government, to extend that equity, to Africa. And so they talk about the cancer moonshot, but actually think in Africa we need a ground shot. A ground shot, which means, as you've heard from my colleagues, there are many innovations and things that are already existing that we can just carry out the implementation research and be able to execute on that and save many lives. And we can deal with the problem of access. The example Tim mentioned, so right now we are running a multi-center clinical trial. It's a clinical trial that was done in Europe and the United States, populations, mostly white populations, and it showed that the time it takes to treat in a prostate cancer patient, usually they have to come in for many weeks, 6 weeks, you can take that time to treat one patient, you can treat 2 patients, and you'll get the same outcomes. So it's called hypofractionation, which means the hypo means fewer times of treatment. They don't have to come in, only have to come in half of the time. And why is that important? It was actually published in the Lancet. My friend David reminded me about that yesterday. So it shows why is that important, because if you come to Africa and we only have one linear accelerator to treat a patient, and the patient travels 400 kilometers or however long and comes to sit in Accra to get a treatment, if you can cut the time that they're going to be here by half, that's tremendous. But it also means that the time it takes to treat one person, you can treat 2 with the limited resources. So the data is out there. The clinical trials have shown that there is equipoise. And so we just need to implement that. And so we've decided that we're going to take that same clinical trial and do that across Africa. It was done mostly in white populations. Let's do that in African populations and compare the data. Once we've established that, we can now come to the Minister of Health and to the First Lady, and we can say, hey, look, this is an intervention we need to adopt more. Mm-hmm. And they can amplify that to the community, and we can adopt that. And it will definitely increase access to care. Mm-hmm. Next, we are actually looking at immunotherapy, the innovation. So that won the Nobel Prize in 2018. And right now, even in the United States, it's so costly that very few people have access to it. Okay? So don't even think about Africa. So right now, we are looking at some of the innovations, some of the work that I did at Brigham and Women's at Dana-Farber and Harvard Medical School. We actually invented technology that can deliver 1/100th of the amount of immunotherapy precisely to the cancer. And that means that you can really reduce the cost of immunotherapy. But we want to test that out in Africa, on African populations as well. So we have funding now to do this multi-center clinical trial with Johns Hopkins and Dana-Farber, but we want to extend that to Africa and include cancer sites here. And so why is this immunotherapy important? Because like we talked about the fact that you're always having late presentation. So patients are always coming when the cancer has spread to other parts of your body. So, that's the kind of treatment that we need to have access to. And so collaborating with our partners in Africa, and they are very brilliant. Professor Twalim Goma in Tanzania. We have Lagos. In Lagos, we actually have collaborators at the cancer center that you helped with the president to start in Lagos, Sialu Cancer Center, and also in South Africa. So now we are bringing these clinical trials to Africa, and the local people are driving it. They are very smart. They are saying this is how we should do it. And I think that that's what we need to encourage going forward.
Thank you very much. And we have to really be amazed at the work that's going on through Will and others who are really taking the initiative to understand how to prevent and treat cancer on the African continent for Africans and being done by Africans. And that's an incredible statement and also incredibly great model for how we should be developing the cancer setting in this continent. But I think that in addition to the things that Professor Ngwa was just saying about taking new knowledge, but many examples of which come from the United States or Europe and are brought here, I think there's an awful lot of opportunity to learn from Africa.
True.
And we can go back, those of you who remember back to Burkitt's lymphoma, a disease that was really described and understood in Africa by African researchers many years ago. And I'd like to ask Professor Kerr about this. It seems like there's a huge amount of opportunity to learn from Africa, and that the whole world can benefit from knowledge that we generate here, things that we can do to improve our understanding of science and clinical medicine anywhere. So global impact through local action. Do you have any thoughts about that?
It's a really important, it's a wonderful point, Tim. And of course we have Professor Lorna Renner, who's made such a lifetime contribution to the treatment of Burkitt's lymphoma. As we said earlier, the more we collaborate, knowledge is power, the better we understand the biology, the basis of disease, the better we understand the pathways involved, the more cleverly we can be in terms of devising new treatments. And although I said earlier that genetically we're very similar, there are some differences, and by understanding those differences, it gives us insight, knowledge, and the power to change. And that's why I think it's a true partnership of equals, because if we want to understand aggressive young Ghanaian woman, which is, I think, probably biologically different than the Caucasian patients that we treat, we can only do this by working together to understand and to develop. And I think Beatrice made a very important point, as does Lorna and Verna, about applying Western medicines wholesale to African populations. That just doesn't actually start to understand better the effect of these drugs in African populations. I think we would be doing a service to the whole community. Why you and I are here, because our science will improve by working with our friends and colleagues in Ghana. So definitely the way ahead.
Yeah, very good. Some really great thoughts. I wanted to make sure we had thoughts from the audience, the participants here. If there's any comments or questions any of you would like to make, there's a lot of great minds in this room, and we haven't covered everything. And if there aren't, I'd love to hear from some of the others here. But anyone else like to maybe stand up? And
questions behind there. Hands up there.
I can't see. Oh, yes, please. Is there a microphone? I don't know. Yeah. Oh, okay.
Actually, this is indeed a great day. This comment is for our health minister. We had a cancer board, and I was wondering what is happening with it, because we were in the communities, we were collaborating with churches, and then suddenly it went quiet. And with the prevention focus, I think this is one of the best vehicles that could move the preventative focus faster, and awareness will be more, broader, or the focus will be broader. So I'm asking our health minister to actually look into that and get it going. Thank you.
And I know from speaking to some of my colleagues here in the country, they are very interested in these cancer boards. Some have served on it. Maybe Beatrice can talk about it because she knows this landscape well. But your point is very well taken, that it's incredibly important that the community voice is heard, that the community writ large, policymakers, advocates, all sorts of people are heard when these policies and plans are made, so that those that create the policy, implement the policy, and then treat patients are also informed by what the community needs and wants. Please, yeah.
Thank you so much for the question. Maybe before the minister comes in,
yeah.
I happen to be the chairperson of the Ghana Cancer Board recently. But when all boards were dissolved, the board wasn't called back. So maybe it's in the pipeline, as is normally said. I just want to chip in that with the community engagements that my sister, who also was a member of the Cancer Board, and we have another two members here, Mrs. Sanan, Professor Opoku Ajima, Dr. Bafu, were all part of the Ghana Cancer Board. Our activities were mainly surrounded with the the chiefs, the queen mothers, the pastors. Because if we want to change anything, we need to go down. We need to go to the community. And you can't go to a community without going to the chief to go and ask for permission to do whatever you are doing. So that collaborative effect is still there, it's beautiful, and we should capitalize on it to be able to move further. So over to you, Honorable Minister.
I think you have extensively dealt with the question, and I want to stand by that protocol.
Wow.
We're working on that. We never dissolved the cancer board. It's like something went awry. That is why we went down a little bit. I'm very honest with you. We started our National Health Summit just yesterday, and the health indicators that I saw didn't make me happy at all, because it looks like we had a mixed type of indicators. Some of the indicators that were all the time going up have started coming down. And the only rationale behind that is a major focus on the pandemic. So all our attention, unfortunately, indirectly, was pushed. We never noticed what was happening apart from our immunization program, which is scoring close to 100% even now. So that's explained it. Then again, we're working on the revised cancer. And so several committees were working, and it's like our activities in the field were slowed down a little bit. So now that has been launched by the First Lady, we are picking it very quickly to start implementing, and we have actually started. When I was looking at the actions, I was taking them here and do my checklist. Which ones have we started? Where have we finished? Which one have we retouched? Virtually, we scored 7/7. We'll talk about it. So we are working on that, and I believe that this will come up soon.
Thank you so much, and we're really grateful that the Honorable Minister is here to hear these words and to respond. Something that, as you just heard, is incredibly important for the next steps in changing policy and implementing some of the things you've heard today as the Lancet Commission. Yes. Oh, sorry. Yes, please, over here. And then. Oh. Mm-hmm. So, over there. Oh. Yeah.
Thank you very much. Nanache, thank you for the opportunity. This goes to Professor Beatrice Uyafi. Talking about registry, recording, and reporting in your delivery. I want to ask if there can be a collaboration with the traditional leaders. Mm-hmm. Back in the communities, you see, I had a dear one died of cancer, a cervical cancer. So I saw some of the symptoms, and then you see that somebody is suffering from something that you think or you want to suggest is cancer. But then you hear the rural folks saying, oh, it's someone who invoked curse on the person. They had arguments about money, about this, about that, and the person invoked curse on that person, and that is why he or she is suffering from whatever she's suffering from. So they refuse to go to the hospital because they think that they believe in the curse that they are saying has been invoked on them. Mm-hmm. So that person will be waiting to die, and eventually the person will die. Then maybe a close relative, maybe a daughter of that person will also suffer from the same thing, and they will say that, oh, when the curse was invoked on that person, they use that relative as to thank the gods. So this continues, and it will eventually happen to several people in one family, and they will still believe in the curse that has been said, has been invoked on them. So my question is, can there be any collaboration with the traditional rulers or the folks in the community so that we can, relay this information to you so that you can record certain things and encourage them also to go to the hospital to report it. Thank you very much.
That's a good question.
You don't.
This is a very important question and assessment. It's been happening, especially for positive family cases. When the mother suffers breast cancer, the grandmother had it, the daughter, and so even sometimes in that family, nobody wants to marry into it. And it's all part of the ignorance. The level of awareness is low. And that's also why we need to involve the traditional leaders. They are very respected. We respect them a lot. And their word is normally final. So we need them to help us in moving this fight forward. They've been doing it, but I think we can do more. The traditional, religious leaders, they have a huge role to play. You can go and see the number of women living in the prayer camps now. So many of them, ranging from breast cancer to prostate cancer to mental health and all those other nose diseases. They are all packed in there. We need to talk to our people. We need to demystify cancers. We need to remove the myths surrounding them, and it involves all of us, not only doctors, nurses, teachers, sociologists, the reverend ministers, the politicians, our strong first ladies who are always fighting for us, the academicians. So everyone here has a role to play. We are not able to do genetic counseling on a large scale because we are not doing the genetic testing. You cannot do the testing without training genetic counselors. And people are not able to afford the testing. It costs about $3,000. Elsewhere, it can even be higher than that. How many families will be able to go for testing? They will ask you, just to do a test? Meanwhile, they want to know whether their daughter can get breast cancer, their sisters can get it. So the time has come, and fortunately with the Columbia University, they're going to train some people from KNUST in how to counsel genetically when people have breast cancer with genetic mutations associated with it. So thank you for all these. That is why we have to change the narrative together. We all have something to do. Thank you.
Good question.
Yeah, very, very good. Melvin Foote, please. And I just, while he's getting the mic, want to emphasize that there is new leapfrogging kind of activities going on around Africa to develop genetic counseling and genetic testing. We have a pilot in Rwanda that we'd like to bring to Ghana, for example. So it is possible to do some of these things with the will and the resources. Please.
Okay, my name is Melvin Foote. I'm with the Constituency for Africa in Washington, D.C. My question has to do with research. What is the nexus between traditional medicine and Western medicine? I'm glad to see the chiefs are here, so I wanted to make sure I put that question forward. Is it only about the support for cancer, or are there some promising research from the traditional side of Africa's medicine? Thank you.
Who wants to take that? Will?
Okay.
Isaac?
Sure.
Oh.
Yeah, Isaac.
Yes, there's a part of the report that deals with building capacity for research into traditional medicine. Many of us believe that somewhere in our forest there's some cure, but then we really need to investigate these cures in order to document that they're efficacious. And that's why it is important. Many of the anti-cancer drugs actually could be traced to some of these, the alkaloids are actually plant-based. So what we need is to do more of the research, but there is need for collaboration. It is not enough to keep them away from us and say, oh, just swallow this, you'll be cured. And that's part of the problem. But my suggestion is also that we need to build a strong health system that is also well-funded, because some of those who forgo care, which is also another component of the catastrophic spending, the high out-of-pocket expenditure in Africa, is that people just give up. And that's why they end up in churches. They forgo care and say, look, sometimes they tell you God will prevent it, or all sorts of things. But we need to work together and not just take on the harms, just hook, line, and sinker. But then we need to dispel the issue of the causes and so on, because that's different from traditional medicine. Those causes are not related to traditional medicine. They're just ways of deceiving our people. Thank you.
Probably what I will add, there are two things that I want to add with the traditional medicine. First, most of them cure every kind of disease. When they are presenting a drug, it can do this, A, B, C, and D. And that puts me off. And the second is probably from my background. I want to know where it was prepared, who prepared it, and what text it has gone through, who has validated it. So I don't know whether it's Ghana Drug Board or whatever, but from the various African countries. So to me, it's real. People are selling poison when people don't know who prepared them and how was it prepared. And, you know, so traditional medicine, I think, is good, but thinking about the future, the institutions should make sure that laboratory A, B, C, whether a cropon or a mampon or where it was prepared and how it was prepared. And then the credibility of even the person who prepared it and the resources, the material they use with all the chemical formulas or everything shown. And two, telling us it cures everything. I believe that being pragmatic, we should not throw the baby together with the bath water. But if I know that the orthodox medicine is telling me that from this laboratory, the chemical compounds is this, blah, 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 I know what is going to be cured, I'll go for it. So as we are thinking aloud, let us take the traditional medicine seriously and make sure that they do the right thing, because there could be something we can gain from, and that will also, you know, this foreign exchange, import crisis and everything, it will also help our finances in Ghana and, of course, Africa.
Yeah.
Critical research and development, where you are encouraged to submit such herbal preparations for analysis.
Yeah.
And so we encourage people, just bring them forward. You can keep your formula, because people also say, well, I don't want them to steal the formula and so on. Mm-hmm. But then, yes, it has to be thoroughly analyzed. I agree with you.
Thank you. These are really great points. There's a question back here, if you can, yeah.
Please, the minister wants to respond.
Oh, I'm sorry, yes.
Just a little to say how much Ghana has advanced with traditional medicines. We have in the ministry actually set up a committee to begin to do clinical trials with some of our traditional medicines that have been prepared. KNUST is training medical herbalists now. We have attached some of them to our orthodox Western hospitals, and people are opting for whether they want prescription on the normal orthodox medications or traditional medications. Our Food and Drugs Agency tests and approves some of these, and they get registered so that they can be prescribed and they are used. And they are checking on several herbal medication, pharmaceutical shops to enable people to go to procure them for certain ailments. But we are insisting that we should have proof of efficacy. And that is why we are pushing them, the scientists. We have set up a committee to begin to test for efficacy within the clinical trial landscape. And when we get into that area, things will improve. So far, none of them have submitted any concoction for cancer treatment. They do for malaria, typhoid, and several other disease burdens. But I believe we will get there. Thank you.
Thank you. There's a question in the back, and while you're getting the microphone to them, I just wanted to say that related to the points that were just made about efficacy and traditional treatments, that goes hand in hand with behavior, belief, culture, and the ability of people to accept and use the medicines that may be helpful to them in a lot of different ways. So being able to take what we know from Western medicine into a setting where traditional beliefs and healing are also there is something that we really need to consider at the same time. So, question.
All right, thank you very much. My name is Dr. Bediako. Thank you for the opportunity to attend this and hear about the work that is happening. I just wanted to draw attention to the fact that we hear a lot about the need for government to support research, but I think it's also important that we open up space for private sector. Biotech in the US is largely not run by the government, but it is run by private companies who drive innovation from academia towards pharmaceutical products. And I think it is important that we recognize that if Africa is truly to leapfrog, we have to have private sector working alongside the government. So I just wanted to indicate that that is beginning to happen in Africa. It's beginning to happen in Ghana. I myself represent a private cancer research company founded in Ghana by Africans and for Africa. And our focus, thank you. Our focus is to do something that you alluded to, the idea that the African genome is the most diverse anywhere in the world. And in fact, by studying cancer among African people, we potentially will revolutionize how cancer is treated for everybody, not just people of African descent. So it would just be great to perhaps hear how government could facilitate the process of young companies like mine being able to establish ourselves. Because obviously, as a young company, you know, things like tax incentives or things like customs duty exemptions when we import expensive equipment would be very, very useful. So just wanted to highlight that the young people, and actually I work with Dr. Wiafi, so I know we're trying to work with her on some projects. But the young people, we are stepping up, and we're excited about doing something about cancer and driving down the cost of diagnostics. It does not cost $3,000 to do a BRCA test. My lab can do it for probably a few $100s. If we do it locally, we can do it cheaper. And so we need to do it locally. Thank you.
Right, thank you. And it's a great point that we spoke about earlier. Africa, innovation and research driving activities that can benefit the world, benefit everybody, not just locally in Africa. And I think that your point is very well taken, that the problem that we're talking about today is not one that any single stakeholder is going to solve. It requires industry, venture capital, government, NGOs, academic institutions all working together. That's something that we see in the United States and Europe a lot. There's no reason why that can't happen here as well, with the support and the leadership of the government and appropriate policy. So I completely agree. That's what we do, and that's what you can do too. So yeah. Tell me if we're getting close to time. I'm not sure.
Tim, I think there are new initiatives being supported by African Development Bank, the Afro-Asian Bank, National Cancer Institute of US, and the African Union Commission to support local initiatives, particularly pharmaceuticals. About 80% of the drugs used in Africa come from outside, particularly from Africa, China and India. And even the active pharmaceutical ingredients also come from outside. So this initiative is for local production. I'm sure they will be willing to support you if you reach out to African Development Bank about some of your initiatives. But it has to be well planned, detailing what you intend to do, what you want to achieve, and how you want to domesticate your research and your findings, and what it will benefit Africa and Africa economy.
Thank you. I'm told that it's time for us to stop. Unfortunately, there's plenty. We're here if you want to ask other questions. But one more thanks to our honored guests, the Honored Minister of Health, Her Excellency the First Lady, and the President of the Chiefs for coming, and all of our other guests. We really are grateful for your support, your time that you spent here with us, and to all of our panelists who really gave us a lot to think about. So thank you very much.
Thank you so much. Would allow the panel to sit. Please, while they are taking their seats, time is fast spent, so I don't know. Honorable Minister of Health, we wanted to make room for you to say a quick word, and then we will go into... Thank you all so much. The various stakeholders will be available to answer some questions. If you would have any advice to, they will be available. We sincerely apologize. We were supposed to. There are people watching all over the world, so we needed to stay within. Honorable Minister, that's your microphone. Thank you.
There's no sanitizer here. Thank you. Excellency, the First Lady, President of the National House of Chiefs, Ojahoho Nanaya Ojibi II, Director-in-Chief, Lancet Oncology, Professor David Coleridge, Professor David Kerr, Oxford University, Professor Wolengwa, John Hopkins and Harvard University, Nime Namei Nananom, distinguished invited guests, friends from the media, ladies and gentlemen, I bring you warm greetings from the Ministry of Health, and I'm excited to be with you on this historic occasion to launch the Lancet's Cancer Report on West Africa in Ghana. On behalf of the government of Ghana, I say Ayiko, the Lancet Group, and all those who made this historic day a reality. I am informed over the past 3 years, an eminent group of internationally renowned oncologists, cancer researchers, health policy experts, and nurses, including many from Ghana and across the continent of Africa, have been working on a major report for the Lancet Oncology, the world-leading clinical journal dedicated to cancer care globally, on cancer care in Sub-Saharan Africa. The Special Commission will today launch the detailed report on the state of the growing cancer emergency in Sub-Saharan Africa, recommend key actions based on in-depth analysis, and highlight case studies and successful models that can be adapted, emulated, or improved across the region to stem the growing crisis. We believe implementation of the recommended actions in this report will be crucial for achieving political commitments in the United Nations SDGs to reduce premature mortality from non-communicable diseases by a third by 2030. Globally, the incidence of cancers and other non-communicable diseases are on the increase. This increase is incidence is seen more in low- middle-income countries. Aging population, poor dietary habits, and physical inactivity, amongst others, are some of the known risk factors accounting for the increase in incidence of cancers and other non-communicable diseases. Exactly a month ago, the ministry launched the revised National NCDs policy and its implementation strategy for the prevention and control of NCDs. That means that we have taken the action 1 that was presented this morning. The goal of policy is to ensure that the burden of NCDs is reduced to the barest minimum to render it of little or no public health importance and an obstacle to socio-economic development. Ghana has defined universal health coverage as all people living in Ghana has access to high-quality healthcare without any financial barriers and leaving no one behind. The UHC roadmap has also been developed to achieve the UHC target by 2030, and we are implementing that at the moment. Cancers and other NCDs prevention and control have been adequately covered in the UHC roadmap. We hope the findings and recommendations in this Lancet report we are launching today guide the implementation of Ghana's NCDs policy and strategy to accelerate the attainment of UHC by 2030. Close the care gap. The theme of the new 3-year campaign against cancers globally, which was rolled out at this year's World Cancer Day, is a critical link in the chain of health awareness programs pioneered by the Union for International Cancer Control to promote greater equity in healthcare for all populations. The campaign exposes significant barriers related to socio-economic factors that prevent many people from accessing life-saving prevention services, diagnostics, treatment, and care. Please permit me to single out for commendation one of the lead commissioners of the Lancet report and a major anti-breast cancer campaigner, Dr. and Mrs. Beatrice Wiafiadei, the CEO of Breast Cancer International, and other charities for their tireless efforts at rolling back mind-numbing cancer statistics. Let me also at this moment mention our First Lady, who has been with us, especially me as a Minister for Health, in doing so much for us. She's done a lot for mother and child care. She's doing a lot for childhood cancers, and her advocacy goes beyond what any of us here will anticipate. The only problem she has with me is the fact that when she's doing her programs and she invites me, I don't attend. Madam, I've taken that comment seriously when you were launching our NCD policy for us, and I committed myself that I'll always be there anytime you are doing such things for us. After all, you are doing it for us, not for yourself, and we should show commitment towards your efforts. The National Strategy for Cancer Control in the short to medium term is intended to reducing cancer deaths by 30% through primary prevention, effective screening, and early detection in a bid to improve effective diagnosis and treatment. Ghana is very keen on efficiency and equity in healthcare to strengthen families and communities, underpinning our President Nana Dankwa Akufo-Addo's appeal to fellow presidents to collaborate on actionable steps required to prevent and control the surge of non-communicable diseases at the launch in Accra last month for International NCDs Dialogue Compact 2022-2030 to accelerate the action plan to actually contain the surge in those conditions. Let me mention that when I was speaking and contributing to the panel discussion, I said I was taking the action plans that has been outlined. Let me briefly take the opportunity to go over what I take as a checklist very quickly. We have already done the action plan. Our strategy has been done, policy approved, launched by the First Lady. We have established a cancer registry at Konfanochi Teaching Hospital in collaboration with the KNUST. We are doing one in Cape Coast University together with the Cape Coast Teaching Hospital. Our next stop will be Tamale Teaching Hospital. And these are all lined up in our strategy document we are implementing. Incorporating cancer care into our benefits package, the advocacy and the good hard work of our First Lady, we have now introduced 4 childhood cancers into our health insurance benefits package. That was announced last month when we announced that. Early screening and detection, this has been advocacy that we have embarked upon. And like Mrs. Wiafiadei said, the board was doing that. We engaged with traditional rulers in some of these things, and that is also on course in our country. What we haven't done much about, is effective palliation. But we have plans to introduce palliation nurse studies into our nursing institutions and the College for Nurse and Midwifery. We've engaged with the Ghana College for Physicians and Surgeons to try and see how we can train specialists into this area. We haven't moved much in that area, but we are working on that. Building and monitoring the workforce, and what we can do very quickly to do that is what I've actually mentioned. We still have problems with where to place our medical physicists. We're having challenges with the regulator and some of them who are practicing in there. But we are working very much. They are very much in the system now. They are fighting for inclusion, and we are supporting them to try to see how best we can situate them to solve some of the challenges we have with their absence. I think it's about all, but that gives an indication of what we are doing along the cancer care spectrum. Nana, President of the National House of Chiefs, the topic cancer in Sub-Saharan Africa, a Lancet Oncology Commission, reflects the enduring commitment of Lancet to partnering in developing economies for the good of the enfeebled, marginalized. The government and the people of Ghana cannot thank Lancet enough for this singular honor and commit to working harder towards the implementation of the recommendations contained in the Lancet Oncology report. I should thank you very, very much for this opportunity to grant me this time to do some little remarks before the lunch. At this stage, Nana Ojahoho, I'll crave your indulgence, and the rest of all the delegates of the distinguished gentlemen and ladies here to invite onto the podium the First Lady to actually do the launch of the report for us. Thank you very much.
Well, Excellency comes in, would have a traditional treat for Her Excellency while we usher her in.
Ghana man penyere Obanu anyamfo eno apomudin eho adwene eda na akoma pono so ya de sempre wa yasoma me se memra o na me matontomo ana mo brenenti Oba pay ya santo asinamo Oba besi a wagina premo ano Oba pa Rebecca Akufuado ma umuswe abrano drama o ni sorry Oba pa kasa sorry na abrano dru eno mimi ya no mi ye ena wanyu wa no nkwati o obani onyamfo e abla no so kasa mami emo akwaba o bapa mewie emo akwaba o bapa o.
All right, so we'll humbly plead the lead commissioners, the two Davids, and Dr. Riafe. The health minister is already there. Ojiahowo would humbly plead can join. And then Professor Jean Nana Upokwachman, the list I had.
Sorry. Oh, thank you, sir. Okay. Sorry? Okay. Not here.
So, on that note, I declare the Lancet Oncology Commission duly launched.
The other commissioners, please, can you join us here? Professor Please, Professor Duhole, yes, Professor Solma, Professor Lona, Dr. Vena van der Poy, Professor Tim Rebeck, Christopher, Professor Christopher, where are you? Okay. So please, all the commissioners who are here today, Dr. Bo, are you here? Please. So all the commissioners who are in this hall are representing the 53 other commissioners who couldn't be here with us but are online with us. Thank you so much.
Kindly, for the cameras, have your document, the book showing. This is the important moment where all the newspapers, online portals, the pressmen we've had from all over the world join us. Take that important single shot. We'll crown her, ladies and gentlemen, with a round of applause. Thank you very much. We're grateful. Let's usher the First Lady back to her seat. Nana Chair, you may stay and then give your quick remark. There will be copies for the delegates. The ushers will help you later on so that all the delegates who were here will receive copies. Thank you very much. Kindly, let's retire to our seats while our Royal Ojiahoho would share his closing remarks. He's the President of the National House of Chiefs. We may kindly retire to our seats as Nana is already on the podium. Thank
you. Your Excellency, the First Lady.
May we kindly sit.
Rebecca Akufo-Addo. Dr. Wiafe, the Minister of Health, and standing on existing protocol. I'm indeed excited. But in the first place, when I was invited to chair this function, I asked myself, am I qualified to do this job? And we have this array of experts. And being a chief and a finance man, I was wondering why I should be invited to chair the function. But now I know why. Nananom are here. They want us to go back, speak to our people, and make sure that we collaborate with the experts and educate our people to take the necessary steps before they are devastated by cancer. Before I proceed, let me say a big thank you to the First Lady and Dr. Wiafe for the wonderful job you are doing for Ghanaians as far as cancer and specifically breast cancer is concerned. Just as I said, I cannot summarize what the experts have said, but I have a few observations to make. Strong advocacy is required. We all agree that all of us should work together, educate ourselves, and talk about prevention and so on and so forth, even before we get the disease. Again, currently, we have a lot of our youth on social media platform. Just as our professor from Cameroon said, the mother is in the village, but the mother is connected all the time. Instead of allowing our youth to use these platforms for entertainment and gossip, let us use the platform to educate them. Let us also fight for global funding to help us. We know that paying out of pocket is not easy at all. Again, suggestions have been made for surgery, but it costs a lot of money. And that is why prevention is always better than cure. We have also been advised to establish natural centers of excellence, and research centers should be established in all countries. And then we should also take timely intervention to prevent cancer diseases. Lifestyle changes are also required. Lifestyle changes are required to win the battle against cancer. Tobacco use is the most important risk factor for cancer and is responsible for approximately 22% of cancer deaths. Fortunately, experts say between 30 and 50% of cancers can be currently be prevented. This can be accomplished by avoiding risk factors and implementing existing evidence-based prevention strategies. What can our African governments do for us? African governments should invest more in health, infrastructure, and human resource development. We know that cancer is not only about health, but it's also about education and finance. And I'm happy to hear from the minister that he have started implementing all the strategies. Thank you very much, Mr. Minister. African governments should invest more in health infrastructure and human resources development. Health systems in Africa should focus more on preventive measures and health promotion as against curative health. Governments can also affect lifestyle changes with very specific and targeted programs. In Ghana, smoking of tobacco use, that was cigarettes, was very fashionable in the 1980s and 90s. This has, however, reduced remarkably due to extensive education on the negative impacts of smoking. Legislation prohibiting smoking in public places and the use of taxation and pricing mechanism to make the cost of smoking prohibitive. These are some of the steps that various governments took to reduce smoking among the youth. Similar measures can be applied to reduce the use of alcohol and the promotion of the consumption of fruits and vegetables. The cancer burden in Africa is high on national budgets. on families and on individuals, and cancer treatment is expensive. In Ghana and some other African countries, there have been calls for governments to include the treatment of cancer on the National Health Insurance Scheme. I'm happy to learn that Ghana government or Ministry of Health has started with the young ones. So bravo to the ministry. Credence is given to such requests by parents' inability to pay for the cost of childhood cancers. In Ghana, there are frequent appeals in the media to philanthropic organizations and individuals for support for cancer treatment, especially childhood cancers. But can the National Health Insurance Scheme, in its present form, support the treatment of cancer? This calls for wider national debate and especially the need for more resources, in particular, the need for patrons of the schemes to pay. So I believe our finance minister will also listen to us, just as our former minister from Nigeria said, yes, you may tell the finance minister, but it's also key. And so we're also using this. I'm also appealing to the First Lady to speak to the 2 years of His Excellency, the President, to come to our aid. Faith-based organizations. In Ghana and other African countries, churches and other faith-based organizations are influential both in terms of numbers and resources, and they should be encouraged to do more and join the fight on the cancer awareness and prevention. Women dominate our churches in terms of numbers. Incidentally, this week, the whole world celebrated Mother's Day, and churches could have focused on breast cancer awareness and lifestyle changes to sustain the campaign. Only a few churches shared chocolate among the women. Additionally, churches could support special training in oncology for at least in the health institutions owned by the churches. Let me speak now to our traditional rulers. Negative cultural elements. In several rural communities in Africa, negative cultural elements which inhibit seeking early treatment of cancers should be eradicated. Culture affects perceptions of health, illness, and death, beliefs about causes of disease, approaches to health promotion where patients seek help, and the type of treatment patients prefer. These are situations where women or wives do not have full control over their issues affecting their health. In certain cultures, a husband's consent is required to seek medical treatment. Breast cancer in particular is a disease, and in some cases, the husband would want to know whether a lady doctor or a male doctor is going to handle the wife. And in some cases too, just as we have heard, some of these people, probably because of high costs, are also sent to faith-based healing camps. And I'm happy to hear from a pastor condemning pastors who keep patients in their hospitals and their camps and will not advise them to go to hospital. So I think the press should take this issue very seriously, and let us speak to the pastors, let us speak to our chiefs to encourage people to make use of the hospitals. Nananom, on your behalf, I am extending invitation to Dr. Wiafe and her team to Kumasi to speak to the 80-strong House of the National House of Chiefs. Thank you, and may God bless all of you.
Thank you very much, President of the National House of Chiefs, adorned with other traditional leaders. Ladies and gentlemen, it's time to say thank you to you. I don't qualify, but we have Dr. Laurentia Jani, who is practicing all the way in Holland, come to say a big thank you to you. Now, if the resemblance is striking, then ladies and gentlemen, you should know that is the adorable daughter of Dr. Beatrice Riafi.
Thank you very much for the introduction. Before I continue, as somebody walking around the whole time, I have one request. Please, after the vote of thanks and the last prayer, could you please stay seated so you get a copy of your book with you? The ushers will come round and give it to you. Let me start by acknowledging our First Lady, Her Excellency, Mrs. Rebecca Akufo-Addo. We are most honored with your presence today. As a young doctor, I think I'm still young, with gray hair. I think we've heard a lot today, and it's up to us, the younger ones, to stand up and make some decisions with the help of the elderly ones, because you are in position. So we will be worrying you on that matter. I'll come back to our Honorable Chairperson, President of the National House of Chiefs, JB II. Nana, thank you very much for your presence, and we are very grateful for your able leadership throughout this program and the events for today. The Honorable Minister, I've sat next to you. We've had some short discussions. We thank you for gracing this event. We know you had a very busy schedule. You just sent them away for another program and you stayed. Thank you very much for that. Incidentally, you happen to be my uncle. So we come from the same town. So I won't be letting you go. I'll be worrying you, because cervical cancer is something that is killing a lot of young women. And as a gynecologist, and specialized in oncology, that is something that is very close to my heart. So I hope to collaborate with you so we can work on that issue, on screening. And I won't leave the former Minister of Health out, because I was very impressed with your open speech. Maybe because you're no longer a minister, so thank you very much for that. But I think after this speech, after this event, you could have a tete-a-tete with our Ghanaian minister now on screening possibilities and what your advice will be concerning screening, especially cervical cancer. It's still my thing. I'll come to you, very beautiful lady. Professor Jane Nana Opoku-Agyeman, former Vice Chancellor of the University of Cape Coast. We are very humbled with your presence as well, and we are so grateful you could make it today to be with us. Thank you. And then we have the President of the Ghana Queen Mothers Platform, Nana Amponsa Dokua. We are thanking you today. And also thank you very much for your input and the questions you asked. Thank you very much. Furthermore, we have the Professor David Collingridge, the Chief Editor of the Lancet Oncology Africa. Lancet Oncology Africa is very grateful for this historic event, and Ghana most definitely is grateful for having the program here held. Thank you very much. I'll come to our lead commissioners, Professor David Kerr from Oxford University, Professor Will Ngwa, John Hopkins, and Harvard University, Dr. Mrs. Beatrice Riafi, let me say just mommy. Thank you very much for putting this program together, for all your efforts and for the hard work. We know something good is going to come out of this. Thank you very much. And the other commissioners that I haven't mentioned who made this possible, we say thank you. You contributed your expertise, your knowledge into making this report a success. The choice of Ghana for this launch of this historic medical report once again establishes the rising credentials of Ghana as a safe haven and also as a place to invest. So, you are welcome, all the delegation that is here from abroad and everywhere. As a gynecologist specialized in gynecological oncology, like I said, I find this report invaluable and convinced that the presence of high-level personalities, both private and public institutions, is an endorsement and a commitment to implement the recommendations contained in this report. May I once again, on behalf of myself, on behalf of Breast Care International, the Peace and Love Hospitals, commend our distinguished audience for your presence and the lead commissioners for this impressive report. Also, our recognition goes to the local organizing committee. We're not leaving you out. You helped to make this a spectacular event. Thank you very much for all your inputs. We are most grateful. And to each and every one of you here today, I say thank you. And as we say in Ghana, ayiko to everyone, and this is just the beginning. Thank you very much.
Thank you so much, Dr. Laurentia Jani. We're sincerely grateful. Ladies and gentlemen, I'll humbly request that the press, we would have a small press conference. There's information we want you to send out there. So once we're done, we meet all the press men out there. In the meantime, just like she rightly said, we'll give you your books, but that would be the time where Her Excellency and then dignitaries on the high table would safely exit while we're prepared. So maybe commissioners would want to, I don't know if we've taken any group photo or something yet, but we did that, yes, while we were up here. Yes, so we used that. But thank you very much. Please, let's give them a round of applause while they go. The traditional leaders will join them. But all who would need all who need copies of the book, kindly remain seated while we find a nice way. Please, security.